You on stage and waiting for your presentation. As we all know about Dr. Usha Naik, she needs no introduction. If there's any problem with a child, the first name that comes to our mind is Dr. Usha Naik. And ma'am has done enormous research in the field of autism and child psychiatry. And it's our pleasure and honor to listen to her today. Ma'am, please come over on the stage. Thank you. Start talking.
Good morning, everyone. Can you hear me at the back?
Yes.
Okay. This is a lovely auditorium. Great morning to be here. And I see Rishi is conspicuous by his absence. So Rishi asked me to talk, and he is a postgraduate student of mine, as is Dr. Ram Subba Reddy. And Shomshekar, Manjula, Pooja, these are people. Pooja I've known a long time, and I'm glad to be here with all of you. I've had a long career teaching at Osmania Medical College to reluctant medical students, and I just told Somshekar that if even one student turned up for my class, I would take the class, because I would say at least you came. So though we don't have a very huge audience, I would say early Sunday morning and Diwali are probably the reason. So I won't take up, I'll be punctual. I mean, I'll finish on time or maybe before. So today Rishi asked me to talk about the importance of child and adolescent mental health. To me, as to more people all over the world, this is becoming a major concern. Either when you watch other people's children or your own, everything seems wrong, and Google Guru tells everything to be terrible and so on. So we don't know what is right and what is wrong. I feel, are there any postgraduate pediatricians here today? No? Achha. Because very often the pediatricians are the first port of call. And in Nilufar Children's Hospital, we were down the corridor from the pediatricians. So there was no stigma because the patients never knew where they were going. If they were from room number 8, they were told to go to room number 14. So they would go around zombie-wise and come and see us. And we'd say, your child has this or that. And mostly they were very accepting of psychological and psychiatric help. So we shall now tell you, obviously all of you who are here today know this is an important topic. What am I going to talk about? The first thing is children are valuable, and I do not think there's anyone who can deny that. I'll very briefly talk about neuro problems. Since I was not here yesterday, I do not know what topics were covered. Was COVID covered yesterday? Screen time? No?
Actually,
Because
they covered the pandemic after what is the problem that we see.
Acha, oh, acha. Okay, did you speak about it yesterday?
No,
No?
madam.
You're not. Okay. Then prevalence of disorders. Then the next topic, I don't know, it's a bit technical, but it's really about general psychopathology. How many are psychologists here, background? Okay, so that's heartening because this is something of that sort. Life stresses and resilience. So I'll start with this. Now, what would you think this picture is?
Maybe in the
Yes. Yes. Yep. And how does this baby look? Smiling. So about 36 weeks old in the womb, correct? And how does this baby look? Miserable, huh? So I was fascinated by this during the lockdown. I used to get a lot of journal articles, especially from Nature Briefing. And normally, nature is considered in all medical and other fields very difficult to access and very prestigious because they're very expensive. But because of COVID, these became free. And every week or twice a week, we get these inputs from nature. And they had this little article about when this was a research project on about 90 babies or 100 scans. And what they looked at is how did the fetus respond to two tastes. The one you saw first, the happy kid, his mother 20 minutes before this picture, or her mother, would have had a little capsule with carrot juice in it. So this baby who got carrot juice, which is sweet, is looking rather happy. And the other poor fellow or girl got kale. I mean, now all of us are eating salad, so K-A-L-E, kale is like, it's a salad. And the second baby got kale. So the one who got carrot, so I'll just tell you about this study. Researchers have the first direct evidence that fetuses older than 32 weeks of gestation can smell and taste while in the womb. Now, all of us knew that Abhimanyu was caught up in a Chakravyuh and all that, but this is scientific evidence of the same. And a fetus is exposed to carrots seem to show laughter faces as in the response below, and those exposed to not so nice kale showed crybaby faces above. So, I mean, this means that all your mothers and grandmothers who've had babies would have told you, eat good food, don't listen to bad talk, don't watch murder movies and all that. So, obviously, this is true. And these scans, they did 180 scans from 99 fetuses, and some of them were scanned at 32, some at 36. So now they found that fetuses can detect taste-related chemicals by 14 weeks of gestation. That means 3 months into pregnancy, the baby can make out taste and odor by 24 weeks. So I'm sure those of us who are mothers would have been very much more careful about what we were eating and smelling if we knew. So this kind of research would make for more responsible parenthood. So that just to say how valuable children are long before they're born. Now, very briefly, I'll talk about COVID and screen time because this is the buzz. I mean, this is what people are talking about. This is a little complex picture. By the way, I'm going to leave my slides on the system, and anyone who wants to look at them can look. Normally, when I give a talk, I leave stuff behind because I want anyone who's interested, like if someone wanted this picture, they can have it. So you can follow up and you don't need to think about learning it straight off. So the COVID-related problems, there were so many things happening. Distress, poor food, abuse. I mean, children who are trapped with parents, parents were trapped with children, and nobody's used to that. I mean, a mother's used to dropping off her child at preschool or at an infant center and going off to her happy IT job or whatever. So if you look at this, it is not only what's happening today, but I believe that COVID-19 generated so much interest because it affected the developed world. And had it been only something in the Congo or in Kerala, nobody would have bothered. But because it wiped out Americans, wiped out Germans, wiped out Italians before we knew what had hit us, it generated so much of interest, so much of research. Of course, some of the papers were nonsense. They were never peer-reviewed. They were published early. But with time, we're realizing that many of the things that COVID did to us, we have understood and learned because it was across the world. I'm sure you agree with that because America and Europe really were involved, we got to learn a lot more. So the distress, poor food, abuse, interpersonal problems of people who did not know what was happening to them. I mean, none of us thought we'd sit a year at home doing pretty much watching Netflix or whatever else we chose to do. And what happens next? I mean, I know a niece of mine had come from Dubai yesterday. She's had COVID 4 times. And she said, a bit not too concerned about wearing masks, and her job involves traveling. But we don't know what the outcomes will be, which is what is scary. Long-term metabolic, long-term psychiatric disorders and so on. Now, this was a study from Germany. All these studies, I put a little bit of the reference, but this is HRQOL. Especially WHO looks at diseases in terms of quality of life. Like, what is the quality of life? Supposing someone has a cancer, do they want to take treatment in stage 4 cancer? Because they'll be alive, but the quality of life won't be good. So they have health-related quality of life baseline assessments in this particular country. So if they looked at the first column, I think, do I have your pointer here? Probably not. You use a mouse? Okay. Okay. Oops. No, I won't use a mouse. So pre-pandemic, if you look at the first column, it was 15%. But this was the first wave, second wave, third wave, it went up to half the people had poor quality of life. And these people had a psychological assessments and health assessments. Now, if you look at anxiety the same way, it went up from 15 to 30. Depression, I don't have one value, so I didn't cook it up. So 10%, not much, 11. Overall mental health problems increased from 18, went up to 31 by the second wave. And by the third wave, I think people were getting fed up. And they decided we couldn't care less what happens to us, we're going to do what we want to do. And if we get sick, we get sick. So I'm sure all of you felt the same. Also, if you look, neuroinflammation, isolation, brain plasticity, and what was the support the health departments were giving people. So I'm sorry, I didn't spend too much time on COVID because I think every newspaper you open still talks, especially that. I'm seeing old friends, sorry. So as far as COVID was concerned, you can still read up, you can still Google. But if you are Googling, please do Google Scholar. Because Google Scholar has peer-reviewed articles which tend to be better than some data which look scientific but may not be. So if you're looking up Google for health issues, whether psychological or medical or psychiatric, please look up Google Scholar, because every article on Google Scholar has a reference. And their tagline is, we have stood on the shoulders of giants. So really Google Scholar gives you scientific knowledge which has been screened. And there's another thing called Retraction Watch, where many journal articles are being retracted because they weren't honest enough when they were reported, like the use of certain chemical formulations, non-approved medications, and so on. So coming to screen time, what I'm going to present is based on several thousands of studies which were reviewed. And AAP stands for the American Association of Pediatricians. And they say there shouldn't be more than 1 hour of screen time after the age of 2. And there should be no screen time before 2. And again, if you look on the internet, you'll see newborn babies looking at the screen, and parents who come to us, they're very proud that their child can navigate their phones and so on. And most parents today treat their phone as a baby minder. Baby's crying, give my phone, and so on. So the Aam Aadmi Party, the AAP is not the Aam Aadmi Party. They recommend not more than 1 hour a day, that too with parental interaction. So if you look at these blue-colored tracks, can we put off this light? Yeah. If we look at the blue-colored tracks, these are the tracks that are related to language and literacy. And these are the tracks that become disorganized when a child has more screen time. In fact, in the next slide, they did say, if you look at this side, lower psychological well-being, the children had less curiosity, less self-control, less emotional stability, difficulty making friends. And you probably have noticed that these children don't share with other children. Like children who are growing up nowadays, they don't make friends, they don't want people to take their toys, and they become rather, I think I would say selfish, which is a strong word for a small child, but they've been so close to their screen and their parents that nothing else seems to matter. I've seen children coming to visit, they go curl up on a sofa with an iPad, and if you say anything to them, they get angry. And I'm sure you've seen this in people if they come home or your child goes to someone's home. The other is on the other side, in about 1981 or so, there was a person called Achenbach, and he found that having disorders like phobias, anxiety, depression, they characterize them into two broad groups, externalizing and internalizing. We'll come to it again, but the externalizing symptoms were more like attention deficit, behavior, conduct problems. Complaining. Okay, good. Shomshekhar and I had a difference of opinion. So, in a systematic literature of 87 studies, this is the number of studies that we looked at this is a review of more than 1 lakh of kids, and they found that there was a small but significant increase in the number of diagnosable psychiatric conditions. Now, this one, I think Pooja, you should look at this. They found that two particular conditions, attention deficit and ASD. ASD stands for Autism Spectrum Disorder. And in attention deficit, they found there was an increase in children having hyperactivity to a level that they could be called a disorder. The other group is ADSD, and this was an enormous study of 84,000 mother-child dyads. And dyads, as you know, is a pair, mother and child. And they found that though the number was not hugely increased, out of 1 lakh children, 0.4% had, 392 out of 1 lakh were more likely to have autism. And more importantly, they noticed that children who developed autism in this study group had more screen time. So if you look at this Japanese study, it was a governmental study, the Cabinet Office, and they looked at children younger than 1 year and found 75%, 85 to 75. That is below 1 year, 85% were using watching the screen, and 75% of 1-year-olds. And this is a huge number of children. Unfortunately for us, though we all talk about these things, we don't do these studies. In fact, in the past, we did ask WHO, and they couldn't sanction these studies on prevalence and incidence. So we have very small, patchy studies and more of center-based reports. But this is very important because most parents, mothers especially, if they're not working, are on the screen all the time. And if the kid cries, they'll give the phone to their mom. It's easier than to get up and walk or take them to the garden. Now, prevalence of disorders. I have an article I bought. Just give to Dr. Ramsu. I was clearing my old home and I came across an article we'd written from Nilofer in 1994. That's like 30 years ago, almost. And in this, we did it in the school health clinic. In the school, in Nilufar, we had a school health clinic where children with medical problems would come. And we were very sincere. We had two scales, Michael Rutter's A and B, and one was for the physician and one was for the parents. And we found that 23% of children attending the school health clinic had a psychological problem, a psychiatric disorder needing intervention. And 23%. And the interesting thing is that 2022, a review article I'll talk about, said overall prevalence of psychiatric disorders in childhood in the community is 24%. So it just goes to show if you sit down and do something properly, your evaluation may not be off a world figure. So that's mine. So in a review, this is the one this Kathleen lady did in April 22. It's a bit of cheating. It's not done in April 22, but this article went online in April. So she reviewed several studies and found 1/4 of youth experience a mental disorder in the past year. And this is our article, which I've just given Dr. Ram Subbareddy. So 23% of children attending a school health clinic had problems which needed help. In fact, several of the pediatricians still use that figure. That is about 1/4 of children coming to you to a pediatrician. This is why I'm a bit disappointed we don't have pediatricians here, because very often parents will ask a pediatrician what's wrong with my child. And the pediatrician, oh, nothing's wrong with your child. If there's no one here, I can safely say that. Except pediatricians trained in Nilufar, they all know a lot. Okay, so then we have this one. This is the article that we were talking about. And this lady had done this massive review and saying that this is the range and this is the prevalence. I didn't have one for mania because it's not that common in childhood, though it does start appearing in later adolescence. So if you look, like ADHD, 3%, someone would say 2%. So there's a big range in these studies. And fortunately for us psychiatrists, we have a manual we follow. There are two versions, the WHO version called the International Classification of Disease, and the American one called the Diagnostic and Statistical Manual. So when we make these diagnoses, we see, for example, you need at least 7 symptoms to make ADHD diagnosis. You need 6 to make autism. So we have this manuals on the basis of which we make diagnosis. We don't just say, hey, that kid looks funny, he may have autism. Or, hey, this kid looks restless, he has hyperactivity. No. You bring a child into a meeting, expect them to sit. They may not sit, but they're not hyperactive. They're in the wrong place. So what happens is that we have, like depression, if a child fails a test, we don't say he's got a depressive disorder, but he's had certain symptoms disturbing his sleep, his appetite, and so on over a certain period of time. So these disorders are not just casual remarks. These are made depending on criteria for diagnosis. And these criteria don't need medical training, but they do need some training before we apply them. So I won't spend more time on this. As I told Somshekha, they will be available. Now the next one, I think in a way psychologists will be better able to benefit from this topic. What has been found is that comorbidity. Hey, I've been talking quite a while. I have only 5 minutes left. So I will go a little faster. But this part is hard. I think it's the only theoretical part of my talk. By comorbidity, we mean, supposing you look at a child and you think this child has anxiety. 5 years later, the child comes back and you say this child is depressed, and so on. So many psychiatric diagnoses in childhood have comorbidity. A child with attention deficit may also have a conduct disorder. Then the problems with the current classification, new studies like genetic studies we find that the genes are the same for schizophrenia and manic depressive, for autism. So what are we looking at? We find the same medication will help for hypomania or manic states, which works for schizophrenia. So there is a kind of conflict within the psychiatrist's mind. Did I make a right diagnosis? So this particular study started like 30, 40 years ago, where people were followed up as many as 38 years in this study. And in 38 years, they looked at children starting from 3 years and examined them every couple of years till they were like 40 and tried to, and these are amazing studies. This one was done in New Zealand. I don't think we are organized enough as a country to do good follow-up studies. And because these are all government-run, very good studies. So in this, they found that why don't we look at a general factor? Like all of you who are psychologists would know, we have a G factor for intelligence, general intelligence. So if you're smart at puzzles or you're smart at memory, you would have very likely a high general factor of intelligence. So now this particular approach is to look at a psychopathology factor. So since we have only 5 minutes left, I would have to go fast through this hard bit. Comorbidity rates are very high. The second point in this is half of the individuals who meet the criteria for one disorder may meet the criteria for a second disorder. And half of those individuals may meet a criteria for a third disorder. So this is true for all of us who follow up children. And they found that major depression, bipolar are linked with ADHD. It's a lot of overlap. Like we don't usually find people who have typhoid also have tuberculosis, but in childhood diagnosis this seems to be happening. And early anxiety may be an early trend for depression. So these are 6 or 7 important points. You have to look at the longitudinal course. What is sequential comorbidity? Sequential comorbidity means today the child may not have depression with anxiety, but if he has anxiety today, 3 years later he may have depression. In this format that we're going to talk about, psychotic disorders like schizophrenia could be included. The important thing is the same genes underlying these disorders, the same treatments. And in many conditions, we have a cutoff point. Why even in blood tests, beyond a certain point, your vitamin D is low. Below a certain point, your hemoglobin is low. So we use cutoff points. But below that cutoff point, people still have symptoms. So this theory in this New Zealand study is there one underlying factor? Like in general intelligence, you know that many cognitive tests can be based on a single general factor, that is mental ability, going from low to high. Similarly, the general psychopathology factor may be externalizing and internalizing. So low psychopathology may be less symptoms, high may be more. So this was the study, which was quite amazing because they followed up more than 1,000 mainly white people from the age of 3 till 38. And they found that externalizing would be alcohol abuse, cannabis, smoking, and so on. Internalizing would be fears, phobias, generalized anxiety disorder. Thought disorders would be schizophrenia, manic disorder, and OCD. Now, OCD is one condition, you see it in movies and all, people very particular. But they are saying in this study that the basic problem is thinking. The other thing, these people with high general psychopathology have these 3 things. They're not agreeable, they're not conscientious, they have high neuroticism. And so the higher the P factor, the worse the person fares on severity, duration, on adult life impairment, childhood development, and family history. There's the same thing that you have externalizing, internalizing, and many people have a brief episode A smaller subset has persistent episode and only a very few become psychotic. That is, they have breakdowns. I had to rush through this because I think I just have about 3 minutes. But the last part is not long. If you look at life stressors, they could be in genetic, in the physical environment, and in social experience. The two, when they look at rats and do these terribly painful experiments, they classify social experience into threat and deprivation. By deprivation, we mean they don't give them proper beds or food, and threat means that someone hits them or whatever. So, the genetic and environmental factors lead to brain development, can lead to pathology or well-being. If you look at these 4 bits, on the right side are the good bits: family dinners, book before bed, the good thing, surprise party, Grand Canyon, that happens rarely but happens. On this side is family illness, death, car accidents. So what happens is children have this spectrum of psychosocial experience. So stress and cognitive enrichment define experience. Stressful experiences are negative and should be avoided. Environmental enrichment is positive and rewarding. For example, just one, verbal abuse. Like there's a huge body of literature about bullying in childhood, and children go through hell in schools. I'm sure many of you remember some particularly nasty child in school who terrorized everyone, or hopefully none of you were the terrorists. So if you look at the age at which happens, in elementary school it might lead to anxiety, in high school it might lead to depression and hostility. So all of these things have been studied extensively. And when a child says, I have a tummy ache, I don't want to go to school, you might ask them. We've had children who say, there's a boy who shows me a knife in school. I mean, all of us would get a stomach ache if we were shown a knife. The last, just 2 slides now on resilience. I couldn't fit in Michael Rutter, who was a great psychiatrist who died last year. He was in Maudsley Hospital in London, which was the children's hospital. And he made a lot of the work that defines what we understand today. I think in the 1960s or so, he looked at one island called the Isle of Wight, and he studied all the children there for psychological problems. But he's done a lot of work on resilience. I don't have time to talk about him. So, this one. For resilience, this particular one is, I've just taken one little aspect of what helps. This interesting study was done with satellite imagery. They looked at satellite imagery of the greenness of the land. Like, you're lucky to be here. I mean, you have amazing greenery on your campus. So they looked at people whose houses came in greener areas, and they looked at the children, and they found that their visual memory was better if they lived in greener areas. I mean, this we all know we feel happy in a green area, but that someone studied the satellite imagery, looked at the kids in those houses, followed them up and found that their visual memory was better if they were in a green area. So I'm not reading this out, I just told you what it is. So if you look at green stuff, you're generally happier. My last slide is just a sum up of resilience, because I would say the person I understood the most from was Michael Rutter, but I've not quoted him today. And what he said was that children can be vulnerable, but they can be invincible. So what we need to do is foster resilience, which is not a trait, but a process. So the last slide is a quotation, and I'm 4 minutes over. Resilience is the natural human capacity to navigate life. It is something every human being has, wisdom and common sense. It means coming to know how you think, who you are spiritually, where you come from, and where you're going. The key is learning how to utilize innate resilience, which is the birthright of every human being. It involves understanding our inner spirit and finding a sense of direction. So that's what I have to say today, and thank you for listening patiently.
Thank you, ma'am. It was a very, very informative session, and the session is open now for your questions and opinions. Please go ahead.
My question is, you talked about screen time, and I'm always curious, what do you recommend? Because nowadays it seems like everyone's always struggling with this. It's always the issue. And 1 hour is the recommendation of AAP. But in general, what do you typically say? Is it better to just cut it off completely for as long as possible? Your opinion, just curious about it.
I'm the wrong person to ask because I don't own a cell phone. No, but I would tell you, the American Association of Pediatrics has an online site you can ask. It is not only 1 hour, but the number of hours increases with age. So it can be 2 to 3 hours in later childhood and so on. Why I personally never had a cell phone is I was at Nilofer, and I have a large family on both sides, my mother's and my husband's side. So they would call me for anything. And as a psychiatrist, I used to be in the RMO room sometimes, and she would say, tell the cook at home, make palak sabji today. And I would say, if someone's telling me I feel like dying, and I say, cook palak sabji, we don't want this intervention. So personally, I find not having a cell phone, which they call an electronic leash, it gives me time to talk to you and to be totally here. And when I walk out of this room, I'm with my family. So that is really why. That is, I did not want work to interfere with my family, and I did not want family to interfere with my work. Having said that, my mother-in-law knew the phone number of the ward boy at the time. When is she coming home? So I am happy without a phone. It also means I miss out on things like chat groups and all, but I really am okay without it. However, since your question is not about me, but what you do, I would suggest you look up this. And the main thing is to realize, especially with parenting, that it is mutual benefit. Like the more time you spend with your child, like green time. I mean, if I tell you that visual memory will be enhanced if you're in a park, you're more likely to go. So I'm amazed at the kind of scientific knowledge we're seeing today, which tells us that what we were always told to do is always good. And the screen time should be, I would think, interactive. It should not be only I sit and watch, but I interact. Like, there's so many interactive science programs for children, and they can do that. So, and it should never be used as a child minder. Like, I'm busy, watch screen time. No. We sit together and do parent-guided interaction because there's so much rubbish on the internet, so much. And social media, I think, is the worst. Okay.
Can I add something?
Sure.
So basically,
Rishi, where were you? Okay.
so the basic American Academy of Neurology recent guidelines say not more than 2 hours of cell phone usage for the children above 7 years of age. Above 7 years, not more than 2 hours, including the screen time. Every screen time is TV, mobile, not more than 2 hours. Above 7 years.
Okay.
And that should be under the guidance of the parents, and it should be only the positive education which is required for the projects and everything, not more than 2 hours. This is the latest guidelines from American Academy of Neurology.
Neurology. Okay, thanks. You got that? Okay. I think the COVID did bad to all kids and parents in school because they had to go online for learning, but they have to get over it now.
I I think in my practice, I feel, and as a person, I have two kids, I feel like it's an issue of, it's a systemic issue, you know. My husband has to work longer hours because we're home and the expectations of work are bigger and bigger. So either I give up my work time and do this because he can't, because he has to earn. It's a systemic issue. So screens have to be used now for school all the time as well. So we can't keep them away. So we count that as soon as they get on the screen to do homework from Google Classroom, it becomes, okay, now I did my homework on the tab, now can I watch it for a little while, right? And so easy to say yes in that moment. And I do notice that when I don't give them screens at all, mood is so much better, sleep is so much better. So I've cut it off completely. But now it's 5 days Diwali holidays, I'm at a conference. My mom said yesterday they were on screen all day, and my clients say the same thing. It's so easy. And as a therapist, I really struggle with giving clients the right, information. The recommendation is always the right. They never tell us how to actually do it. So it seems like cut it off completely is the best answer. Like you said, don't have a cell phone. That's a great recommendation.
No, it's not great. It's not. You won't be able to do Amazon shopping. But no, I think that you should talk with parents. The peer group influence is very strong, and if the child says none of my friends use cell phone except me, that would be very strong. So if mothers and fathers of children get together and say no, this is the time, then they'll accept it, because the rule is for if you give 1 hour and someone gives 4 hours, the kid will not be happy with you.
So we are running short of time. Sorry, we are running short of time. So keep it crisp. Yeah, please go on. It was an opinion you wanted to add?
Opinion I have to add here. Like to add the point here, like schools are going into a bridge mode, offline plus online. So they are teaching and the notes and everything they are sending online, and we are unable to avoid that part. Notes and everything is coming online and they have to see the screen and write. Where they are spending more than 2 hours and 3 hours on the screen.
Sorry for saying, but could you print out those notes?
Print out,
Yeah,
yes.
print out the notes and learn from the notes.
How much, like print out, again we are wasting the paper and writing the notes. Like
No, it's worth it. It's worth it.
Usually what I advise is to get a desktop which is in the center of the room so that anybody can monitor, rather than giving a laptop and mobile where they can carry everywhere. So buy a desktop which is much cheaper than what you are buying. Keep it in the center of the room so that everybody can monitor, and it can be controlled.
Central.
It cannot be installed in everywhere and used in such a way.
Very
You can use this. You can use desktop instead of laptop for doing the work. That can be one solution you can give.
I think Rishi should have a seminar on screen time. Because this is some topic we can never finish talking about.
Yes.
And we have other people to say.
So I see there's a lot of excitement with screen time, and as ma'am said, we should have a separate conference on screen time and get all the opinions. So thank you, ma'am, for the wonderful session. Just summarizing. So what we take away from the session is mental health is something that starts from the womb. And the second wave hit us very badly, 31%, a reliable source that is, to know. And then Ackenbach is not very old research. It's even, today also it's valid. I want you to read up on that. And then presently, 24% of the children who visit the pediatricians need intervention. That is something alarming, and we need to take this home today. And then diagnosis is not made subjectively. Objective criterion is important. And then longitudinal history is very important. That's where psychologists come in, because we have all the time in the world to listen. And then in the end, ma'am advised us to read Michael Rutter for the concept of resilience. And this is something which we all can build in us ourselves and also instill in the children who come to us for help. Thank you.
I invite Dr. Ram Subbareddy sir to felicitate ma'am. Now I invite Dr. C. Manjula Rao, clinical psychologist from Apollo Hospitals, Hyderabad, to have a talk on classroom behavior problems among peer and its management. We'll have one more talk and then take a tea break. I'm sorry for the wrong announcement. Now the talk is by Dr. Suresh Daripalli, Assistant Professor of Psychiatry, Gandhi Medical College, Hyderabad. He'll be talking about social media influence on body image disorders, which is the upcoming trend. I request Mr. Somashekar to be here in the stage. Or Mr. Naresh, please come back to the stage. We need help on the PPT. Any more questions from the audience? We have a 2-minute break now. Any questions, any topic for discussion meanwhile?
Hi ma'am, I would like a minute.
Oh, thank you.
Hi guys, hi everybody. I was the one who was posting that brochure in the group.
Oh, yeah.
Yeah.
Okay, alright.
Hi ma'am. So we are, I'm an assistant professor in Maulana Azad National University. It's a central university in Gachibowli. We are neighbors, SU and us. So we have been sanctioned a project with the Ministry of Electronics and Information Technology to develop an application to teach children with intellectual disabilities. Yeah, as Rishi sir, we had a talk last week. He said 2 hours of screen time. I said 45 minutes of screen time is enough for our application. But then I would invite you all to collaborate with us. We need your guidance because I'm an the IT brainchild. I don't know anything about psychology, psychiatry. Yeah, I do have an interest in learning disabilities and disorders. But then we would invite you. There is a QR code in that application. There's a link which you could click. I'll pass the flyers by. You can have a look. And if you want to discuss, we are open on WhatsApp or anywhere you want. I'll pass you the flyer. Okay? Thank you. Thank you for your time. Thank you, ma'am.
Hey, thank you. We have 2 more minutes. Can anyone? Can anyone fill in the gap meanwhile? This is how we need to manage our stress in the last minute. No option.
Please on the answers. WhatsApp messages?
Yeah, I can do that. We can. And you'll know how if it doesn't plan, it might take a hitch and to manage it. Yes, yeah, right.
It's not great.
Good morning, everyone. Thanks for the opportunity to talk in front of so many psychiatrists as well as psychologists. And today I am going to talk on social media influence on body image disorders. And is it an upcoming trend or not? So, my overview of presentation is I am going to give 2 case scenarios wherein how patients present with body image disorders to psychologists or to psychiatrists, and definition of few keywords to make you understand the topic easily, and prevalence of social media use as well as body image disorders, etiopathogenesis, manifestations of individual body image disorders that are associated by social media use, management, and question and answers. This is the first case wherein a 20-year male patient was referred from plastic surgery department to psychiatry with excessive concern about facial asymmetry since 5 years. On history, patient started following a social media star who is a singer and a model on Instagram. Patient started spending a lot of time on watching his videos and posts on Instagram, and later he felt that his face is asymmetric and want to correct his face so that he can look like perfectly like the star he is following. So on examination, patient growing beard to cover up the imagined flaw in facial asymmetry, checking recurrently in front of mirror as well as taking multiple selfies and comparing themselves with his real body image as well as with images he saw on social media, and avoiding behavior in the form of not socializing. Whenever there is one-to-one confrontation or one-to-one interaction is required, he is standing in an angle so that he cannot make an eye contact and others wouldn't appreciate his facial asymmetry. And also stopped going to college since for last 2 years. According to DSM-5 as well as body dysmorphic disorder questionnaire, he was found to be positive for body dysmorphic disorder. And this is the second case scenario wherein a 14-year-old female child brought to OPD with complaints of reduced the meal size to half and eating alone, lost weight significantly. When confronted by parents about her behavior, she would tell that she is fat and want to lose weight, also want to look like a Korean star whom she watches in web series and follows her on multiple social media handles. So on examination, she is thin-built, pale, with mild dehydration, with lanigo hair on the body, not making an eye contact, preoccupied with her body image, afraid of gaining weight. According to DSM as well as eating disorder inventory, she was found to be anorexic, suffering from anorexia nervosa. These are the few definitions to make you understand this topic easily. One is body image. Body image is perception you have of your physical self, and the thoughts and the emotions that results from this physical self is called body image. Body dissatisfaction is inconsistency between one's real body and the idealized body or desired body. Social media is every website and online mobile app with user generated content is called social media. Now coming to the people, how would people with positive body image look like? They will have a clear perception about their body shape. They celebrate their natural body shape and they appreciate it. They feel pride in their body and they accept their body as it is, and they feel comfort and confident in their own body. Those with negative body image will have distorted perception about body shape, and they believe that others are attractive and that own body size and shape is a sign of failure. They often feel shame and they are self-conscious about their body. They feel discomfort and awkwardness in their body. Coming to the prevalence, almost half of the world population is using social media handles, and which are more than thousands in mobile apps as well as websites. Hence, it has become large part of today's culture. Hence, it must be associated with some certain positive as well as negative effects. So, there are studies that show that 87% of the women who compare themselves to the images they observe on social media, with half of them emphasizing that this observation or comparison is unfavorable. Whereas 65% of men compare themselves with the images they observe on social media, and almost one third of them indicating that this comparison is unfavorable. So, the extent to which social media influences body image or body dissatisfaction is debatable because there is inconsistent evidence to state that social media has positive or negative impact on body image issues. There are studies showing that social media has no effect at all on body image, and also studies showing that there is a positive relationship between social media use and body image disorders. But there are other studies that emphasize on indirect influence of social media on body image by increasing the peer competition. So thereby it is increasing comparison between peers and increasing body dissatisfaction. So a recent meta-analysis of 63 independent samples observed that small positive and significant relationship between social media use and body image disturbance. So even the same meta-analysis found that influence of social media use on male and female is similar. So these are the most common body image disorders that are associated or exacerbated by social media use. One is anorexia nervosa, bulimia nervosa, binge eating disorders, and body dysmorphic disorders. Approximately, anorexia nervosa has a lifetime prevalence of 2 to 4%, with 6 times greater prevalence of mortality when compared to general population, and out of five, one will die from suicide with anorexia nervosa. When look at gender disparity, almost 10 times more common in women than in men, and its typical age of onset is early to mid-adolescence. Bulimia nervosa prevalence is around 2%, and there is increased mortality, but definitive studies required to compare itself with other eating disorders. Again, gender disparity is almost equal to anorexia nervosa, that is more common, 10 times more common in women than in men. Age of onset usually late adolescence to young adulthood. Binge eating disorder, its prevalence is around 2 to 6%, and the mortality risk is not yet clear, but it obviously increases mortality because of obesity. And when gender disparity is looked at, it is almost similar, and age of onset is later than anorexia and bulimia nervosa. Body dysmorphic disorder prevalence is about 1.7 to 2.4%, and the mortality risk is no clear increased risk of mortality other than having comorbidities, particularly psychiatric comorbidities that may lead to suicide. And gender disparity, when community studies indicate higher prevalence in females, while clinical reports indicate roughly even male-female ratio. Typical age of onset is adolescence. So core symptoms of anorexia nervosa, they will be having persistent and relentless drive for thinness, intense fear of gaining weight or becoming fat, disturbance in the way they perceive their own body weight or shape. So they will be having some compensatory mechanisms when accompanied by binge eating or purging type. And when it is restricting type, there won't be any compensatory mechanism. Usually people with anorexia nervosa will be at lower end of weight for their age and height. Duration criteria to diagnose anorexia nervosa is if these symptoms are persistent for more than 3 months, then we can diagnose anorexia nervosa. Bulimia nervosa is characterized by eating large amount of food in discrete periods of time, definitely larger than that most people would eat in similar circumstances and period. Along with that, people with bulimia nervosa lack the sense of control over eating during that particular episode. Again, bulimia nervosa is associated with compensatory mechanisms. These compensatory mechanisms in anorexia nervosa, bulimia nervosa are usually inducing vomiting, using laxatives, diuretics, stimulants, thyroid pills, as well as prolonged exercises, prolonged fastings. If this behavior is present for more than once a week for more than 3 months, then bulimia nervosa can be diagnosed. When we look at their weight, it is greater than or equal for their age and height. Binge eating disorder, almost symptoms are similar to bulimia nervosa except for compensatory behaviors, and the same duration criteria is 3 months, and there are no specifiers for binge eating disorder. Body dysmorphic disorder is characterized by preoccupation with physical appearance and subjective flaws, presence of repetitive behaviors in the form of recurrent checking and covering the imagined flaw. Again, compensatory mechanisms are present, like covering the imagined flaw by excessive grooming or avoiding social situations. Duration criteria not mentioned either in ICD or in DSM. There are different specifiers for body dysmorphic disorder, that with muscle dysmorphia, wherein people with muscle dysmorphia will have preoccupation with perceived low muscle mass. So they try to build their muscle mass by excessive exercises. Other specifiers are with good or fair insight, with poor insight, or delusional beliefs. So etiopathogenesis, coming to the etiopathogenesis of different body image disorders. It can be biological, evolutionary, psychological, and socio-cultural. Social media is used as socio-cultural factor for essentiating body image disorders. This is a tripartite influence model of body image disorders, wherein media, family, and peers act as a formative influences. Those ideals that are shown in media, family, those culturally sanctioned family beliefs, and peer pressures about their appearance and bullying part will start make people to compare themselves with others, and those ideals which are seen in media, which are followed in family, which are expressed by peers are internalized. Then they develop body dissatisfaction, that is inconsistency between their real body and this internalized idealized body. Then they develop low self-esteem, bulimia nervosa, anorexia nervosa, and this is body dysmorphic disorder with muscle dysmorphia. Finally, they land up in other comorbidities like depression and anxiety. So, social media not only has negative effect, it has certainly some positive effects also. There are social media accounts as well as groups that can promote health and wellness and fitness. There is a tag that is running on Instagram is like Fitspiration. There are plant-based food accounts that can all be inspiration for individuals to follow these accounts and make their life and develop positive body attitude. So, how to prevent body image issues that arise out of social media use? So, first thing is take a break. If you feel worse after scrolling, take a step back and see how you feel after disengaging from social media handles. If you feel better, so there is no shame in putting back your phone, whether for few hours or days or weeks. So all these breaks will improve your mood as well as sense of body positivity. And unfollow those accounts which don't make you feel good, and pay attention to accounts, people or images that lift your mood as well as promote body positivity. So find a community on social media which promotes body positivity and join supportive groups if necessary. And one thing I tell my patients is that one of the biggest shifts they can make is they have to replace the content that leaves them worse with the content that makes them feel better when they consume it. So, coming to management, understanding the underlying triggers, emotions, experiences that influence your body image, challenging negative thoughts you have about yourself and your body, learning how to experience your body without judgment, and internalizing social pressures. And developing greater self-worth and healthy coping mechanisms to deal with challenging emotions. When coming to the individual disorders, anorexia nervosa is treated by nutritional rehabilitation and weight restoration. So, usually pharmacotherapy is not required for nutritional rehabilitation and weight restoration. In most of the cases, depression as well as anxiety, which is almost comorbid with 80% of the patients with anorexia nervosa, will come down with nutritional rehabilitation and weight restoration. So pharmacotherapy is required when there is severe comorbidities, and bulimia nervosa usually cognitive behavior therapy as well as antidepressant, which are equally effective for patients with and without depressive symptoms. Among SSRIs, fluoxetine is used as the medication of choice for illness. TCAs, monoamine oxidase inhibitors, atypical anti-epileptic agents such as topiramate have also demonstrated efficacy in randomized controlled trials for bulimia nervosa. Binge eating disorder, similar treatment, but topiramate has better results when compared to other TCAs and SSRIs. Lisdexamfetamine is a stimulant drug which is recently approved by FDA for short-term treatment of binge eating disorder. Body dysmorphic disorder, SSRIs are efficacious in the treatment of both body dysmorphic disorder with good to fair insight as well as delusional body dysmorphic disorder. CBT for OCD is modified for body dysmorphic disorder. Social media can exacerbate body image disorders and may trigger or worsen certain genetic or psychological predispositions, and also intensify pre-existing mental health conditions. So, we'll have a 5 question and answer sessions. So, anybody can answer from audience. These are the simple questions made for you to understand the topic easily.
A. Slides on the planet effect.
A is the right answer. What is the common age of onset of body dysmorphic disorder? C is the right answer.
Hey, all right answers for us.
Individuals with dash disorder exhibit a persistent and relentless drive for treatment. Right answer.
Right again.
Which gender is
We
more?
have to say
Which? C. Female.
Hey, it's B.
And the last question, which of the following differentiate bulimia nervosa from binge eating disorder?
We had this yesterday too.
Compensation behavior.
B is the right answer.
Very good. Japse, now what gift are you going to give us? You have to be clear
So
like
many
that.
answers.
Thank you. No, please. We are already running out of time. Can we continue with the topics or do you want to have a short tea break? Tea break. Wow. So just wait for a minute. I invite Dr. Ramdu Subbareddy sir to conclude this presentation and to felicitate Subbareddy. Students and my dear colleagues, we just have 5 minutes of tea break. Please come back soon.
Social media influence and body image disorders. Now Suresh has already presented the topic. If you have any questions, you can ask. No?
Any particular
It was
studies?
really good, sir.
It was very good.
Yes.
Thank you.
Any particular studies you have noticed? Is it a direct relationship or a casual relationship you have noticed in the body? Because there are many other reasons for bleeding. Social media.
So, are there any studies he is asking?
Yes. Yes, sir. The conclusion is it can exacerbate who are biologically vulnerable or they are already having any pre-existing mental health issues, it can exacerbate. So there is no direct relationship.
It's a casual relationship.
Yes.
Can exaggerate.
Yes.
Sir, I have a question. On the same lines, then, do you think that the reason for that is because it was interesting? Because we always think social media, oh, it definitely makes body image worse. The research is showing maybe not. So then, do you think it's because if you already have body image issues, you go look for those sites only? That's one of the reasons.
Yes, most probably one of the reasons.
Yeah. Any other things that you think could be also affecting it? I'm just curious.
Usually those who have negative body image issues from the beginning, as well as those with personality issues, particularly borderline personality and OCPDs, histrionic personalities, they will compare themselves with social media. Apart from anxiety and depressive disorders.
So any quick scales that we can use in assessing?
Yes, for eating disorders, there is a eating disorder inventory is there. For body dysmorphic disorder, a direct questionnaire, body dysmorphic disorder questionnaire is there.
Whatever is available on the net or are they standardized?
Yes, they are standardized.
Can you name the scales? Eating disorder.
Inventory. Body dysmorphic disorder questionnaire.
So, any questions from the audience apart from these two? So, if we do not have any questions, we will end the session. Thank you, Suresh, for the presentation.
Go on there. Sir, please felicitate Suresh Garu. Tea is ready over there. We all can go and have a quick tea and please come back soon. We are going to play a nice game in the next presentation, so come back.
So,
I want, but I didn't. I saw your face, so that's kind of training. And 8:30 వెళ్తే 5:30 6 కూడా ఉంటుంది. ఒకటి కూడా అసలు లంచ్ టైం పక్కనే ప్రీతిని అపాయింట్ చేశాను. ప్రీతి ఏమో వెకేషన్ వెళ్ళింది, తను వచ్చింది శ్రీజని so I have to train for 1 week, 1 week to 1 month. And the assessments 3 months wait list.
And even
నాకు 25 years నాకు వచ్చిన వాళ్ళందరూ 60%. I'm not having your presentation is there. So వాళ్ళు ఏం చేస్తున్నారు తెలుసా, ఎంఏ డిస్టెన్స్లో చేసిన ఎంఏ క్లినికల్ సైకాలజిస్ట్ తీసుకుని మనం పెట్టేసుకున్నాం. డిస్టెన్స్ వాళ్ళకి ఇంటర్వ్యూ కండక్ట్ చేస్తే అసలు ఏం అడిగినా నేను ఏం అసెస్మెంట్స్ చేస్తాము అనుకుంటే కూడా నేను క్లినికల్ సైకాలజిస్ట్ చేస్తాను తర్వాత వాళ్ళే 60 days లెక్చర్స్ బయట సెంటర్స్ ఇస్తున్నారు. నేను మీకు ఆర్సీ రిజిస్టర్ పే వాళ్ళని తీసుకొని ఉన్నారు సరే ఇంటర్వ్యూ పెట్టేస్తాను. బేసిక్ అసెస్మెంట్స్ ఏం చేస్తారు అన్నీ వీడియో అసెస్మెంట్స్ అన్నీ పెట్టారు. ఏ అసెస్మెంట్ ఆ పేరు దే ఆర్ డూయింగ్ అసెస్మెంట్స్ అండ్ గివింగ్ ద రిపోర్ట్ వాట్ అసెస్మెంట్ దే ఆర్ డూయింగ్ అండ్ అబౌట్. సో ఏ క్వశ్చన్ సో నేను అట్లా మళ్ళీ ఇప్పటి వరకు వచ్చిన పేరు తగ్గిపోతుంది కదా, స్టాండర్డ్ తగ్గిపోతుంది. ఇప్పటి వరకు ఎక్కడిపైనా ఆ బ్రాండ్ ఉంది. తీసుకోమని తర్వాత చెప్పాను ఓకే అన్నారు. మళ్ళీ నేనే గ్రూప్లో పోస్ట్ చేయడానికి చేశాను శ్రీజ. షీ వాజ్ ఆల్సో డిమాండింగ్ 1 year ఎక్స్పీరియన్స్ క్లినికల్ సైకాలజీ ఓన్లీ 1 year ఎక్స్పీరియన్స్. 1 year ఎక్స్పీరియన్స్ అమ్మాయి శ్రీజ నాకు రావట్లేదమ్మా నేను చెప్పాను నాకు 20 years నాకు నేను క్లినికల్ స్పీకర్లో చేశాను, పిహెచ్డి ఎస్సీలో చేసి వచ్చాను. సో ఎంపీ పిహెచ్డి అండ్ దెన్ మళ్ళీ ఇక్కడ చేశాను. ఇవన్నీ ఐఎమ్ బేసికలీ స్పెషల్ ఎడ్యుకేటర్ అండ్ టీ రిజిస్ట్రేషన్స్ ఉన్నాయి. స్పీచ్ స్పెషల్ పీరియడ్ సపరేట్ రిజిస్ట్రేషన్ క్లినికల్ సపరేట్ ఇచ్చారు. ఇన్ని ఇయర్స్ ఎక్స్పీరియన్స్తో ఇంత ఈ క్వాలిఫికేషన్ అంత డిపార్ట్మెంట్లో కానీ నాకంటే అంటే ఫిజియోథెరపీలో ఓటీలో దే ఆర్ గెటింగ్ వాట్ పే అండ్ ఐఎమ్ నాట్ గెటింగ్ మోటివేషన్ టు వర్క్ యాజ్ వెల్. అంటే వి థింక్ ఆఫ్ ఇట్ అన్నారు కానీ బట్ రియల్గా అనడం ఏమీ సో డిసెంబర్ 31st అంటే 3 years చేసినప్పుడు అంటే ఐఎమ్ జస్ట్ జనవరి 1st 2020లో చేశాను. అది 3 years సర్టిఫికేట్ ఇప్పుడు వచ్చిందంటే 23 years మా ఓన్ సెంటర్లో
अभी आओ मैं हेलो रेशमा, कैसे हो आप? वेरी गुड वेरी गुड. इधर देखो फिर दोस्त, इधर देखो.
पहले से अब चलो आप काम करवा लो. मैं सुन रही हूँ. ऐसे एक्टिविटीज एक वीडियो सोशल स्किल्स ट्रेनिंग पे
నీకు వస్తుంది కదా
काम में आ गया.
నెక్స్ట్ क्यों आपका बात है ना 3 बजे तो
ये लाइट ऑफ वैसे ही रखी है।
हाँ
डिस्प्ले समझ में नहीं आया।
वो कि उनका फेस ब्लैक आ रहा है
हाँ वो भी एक है।
ब्लैक आ रहा है
ब्लैक है।
There are two systems.
That's not my
Yeah,
laptop is
that's
connected.
what, that's what. Let him come.
Let him come. Hello everyone.
Hello. So I am the genetic counselor working for Hyderabad Institute. Yesterday in the session there were a lot of discussion regarding the genetics and genetic disorders. If anyone have any queries regarding genetics and genetic disorders, you can come in touch with me in the lunch session. Okay. Thank you. Venkatesh.
Welcome back. I request Dr. Ram Subbareddy sir to chair the session. And now I invite Dr. Adeseshama Garu, Professor of Psychiatry, Government Medical College, Ongole, to talk about rational use of psychotropic drugs in children and adolescents.
Hello. So most of you might have seen the prescriptions of the psychiatrists regarding the psychotropic drugs. Some of the drugs must be known very well. But here the important thing is, while prescribing that, we should know the side effects more commonly. Because some of the side effects are very serious and dangerous, and it causes a lot of complications. So better to know the side effects most commonly rather than mechanism of actions. So Dr. Adeseshama Madam is going to present regarding the psychotropic drugs. Madam was our faculty in Nilofar Hospital, worked as assistant professor, and she did post graduation in Institute of Mental Health. Now she is working as a professor of psychiatry, Government Medical College, Ongole, and she is both pediatrician and psychiatrist. She is having her diploma in child health, and she is having MD psychiatry. Thank you, madam. Please go ahead.
It's a nice introduction, sir. I have a small announcement for the speakers. We are going to keep a buzzer at 25 minutes, so please try to conclude immediately after listening to the buzzer. Thank you so much.
So, good morning, sir, and good morning, all. Here, my teachers, Dr. Usha Naik, ma'am, Dr. Ram Subbareddy, sir, Dr. Ganga Ram, and my colleagues, Dr. Rishi, Dr. Suresh. So, I'm very proud and I'm blessed with these people to work with them. And Dr. Gauri, ma'am, Dr. Somashekar, all these people are known. and with a caution from Dr. Somshekar that not to give so many details about the drugs, but the importance of drugs. So he advised me that, so okay, this is for everyone, not only for psychiatrists. So with that concept, I started rethinking myself about the presentation. So then I thought, okay, I shouldn't sit in this chair as a treating doctor, but I should oppose it to my seat, thinking how a patient thinks and how a patient's caretakers, the parents thinks, and the referring doctors think about the drugs. In that way, I started presenting my session. So the first biggest problem in child psychiatry, as per my knowledge as a pediatrician and psychiatrist, is the diagnosis. Diagnosis is a very, very big issue. And the second most and the foremost and bigger one is convincing the doctors, the referring doctors, whoever, like the psychologists, pediatricians, general practitioners, whoever, and the family members about the treatment and about the diagnosis. Again, a very big, like it's a big konda right up. So that is the issue for me. So with that concept, I started working on my presentation. So second, after convincing about the diagnosis, advising about the drugs. So people start seeing in that way to me, and as if I'm a tiger, and so that is the issue. So I started in that way. So what are the common doubts as a parent thinking about their child and caring about their child? So what are the common doubts? So one is about the drugs lifelong dependency, and so that is the biggest common doubt. And the second is how it affects the intelligence and growth of the child. And safety and side effects, of course, they come in that way. And the stigma and bullying about the peers and by family members and others, relatives, everyone. And the other thing is that drugs are really useful. Only the therapies or the advice or counseling, preaching, pujas, vratams, and all these are enough. And this is from like the core people of doctor community. I listened this comment from them. They haven't noticed the importance of the psychological growth. As a pediatrician, even myself, I have only seen the progress of the child as in like the parameters what we routinely use, the milestones, motor milestones, not the intellectual and the psychological milestones. We didn't give much importance to them. Maybe that is the reason nowadays, especially during the COVID season, parents were convinced that giving the food to the child is enough. That is the reason they have given the mobiles to them and the iPads or whatever gadgets to them, and they think that feeding is enough for them. They don't want to harm their child without knowing the importance of the psychological growth. They have adapted that habit. So the lesser importance to the psychological growth. And one more thing is that as Indians, we have a strong family culture and we have a strong Indian heritage, whatever that legacy we are having, that we are immune to psychological disorders. This is a denial, psychotic denial for me. And if not treated, the psychiatric diseases, what are the consequences? So these are the common doubts raised by the parents and raised by the doctors to the psychiatrist, and we have to answer these questions. So then I thought how to convince them. So what I thought is that Satyameva Jayate is the best thing. Whatever truth that is with us, we have to tell them. If we are standing with that truth, definitely we are going to conquer. So with that thing, so I looked at the science. So what the science has provided us. So with that evidence, I am going to give my lecture. So what is the evidence at present we are having? So for the last decade, if we see at the science has given so much knowledge about the neurotransmitters. Leave about rest of the things, the words, whatever, like the symptoms. But now we move to the evidence. We have much knowledge about the neurotransmitters and the neural circuits, and how the neural circuits are changed in various psychiatric disorders, and including the child and adolescent psychiatry, and the brain systems involved with these malfunctionings even in the childhood psychiatry, and the genetics research to identify the genetic cause for the psychiatric disorders like the ASD, the gene loci, and the ADHD, the Huntington's. So for so many disorders, the bipolar, all these things they have identified. And the best evidence is from the neuroimaging. The functional studies, we are in India, especially even in Telangana also, we are at the fMRI stage only. But the SPECT, fMRI, PET scans, the TTI, all these things, they have thrown so much light over the neurological base, the evidence for the psychiatric disorders. Once we have the evidence, we can treat. So that is the advantage now we are having. So with that evidence, so the NA, see, this is mainly from the Western only, because all the psychiatry and the psychology, everything we adopted from West. The American most top priority institute, that is the NIH and the NIMH. So they started converting this knowledge into the treatment aspects. So they start funding so many trials. So this NIH and NIMH funded trials are like, we can trust them, we can rely on them. So they issued certain guidelines for treating the children. So this, and they have adapted some laws also, where the drugs which are useful in adult psychiatry, they have given an act, that is the FDA MA Act, to extend the clinical trials for 6 more months. It's a compulsory. They have to do the trials for 6 more months to conduct in the children and adolescents. So from those studies, we have all the evidence right now. So this is very important. So both the NIMH funded trials and so those are the federal funded studies, and the private trials, both are now we are having the evidences we are having. I don't want to quote all the studies, but important studies I want to quote. So even after this, relatively few, and still the FDA has so much cautious about warning, like advising the medications. After taking everything into consideration, they have given FDA approval to certain drugs in certain conditions. So we can safely use those drugs with confidence. And second more thing is, for me, drugs are always, they are sharp knives, sharp swords. We should know how to use them. So if you want the good result, you should know how to use the sword. If you won't know how to use it, definitely catastrophe is occur. So coming to the diagnosis, problematic behavior, how to confirm. What is the confusion in this? See, because most of the children, most of the times they are fearful, they are fussy, they are so much hyper. That is a common word we listen from the parents. So this is quite normal to the child. If a child sit idly without doing anything, then we have to think the child is abnormal. If the child is active, bubbling, everything, that is normal for them. Then how to differentiate? For this, as a clinician, as a treating doctor, we should have the solid knowledge about the child development. What is the normal child development and what is the abnormal child development? And we should know what are the symptoms that are abnormal at certain age and what are the symptoms that are normal at certain age, and the time frame at which these wax and wane. This is very, very important. Unless you know about the knowledge about the normal child development, normal developmental milestones of the psychological growth, we are not able to diagnose a child correctly. So what are the common symptoms of referral? The first and foremost is lack of developmental progress, that is the developmental delay. This delay may be in many aspects like the speech, motor, and the social communication, language, everything like that. And developmental status affecting clinical presentations. This is because of the growing brain, the classical manifestations of depression or mania or whatever, that is not present in the children. Okay, so like the classical manifestation in depression, the child is whatever, the adult is dull, sad, sitting aside, but here the child, he can't sit like that. So he is irritable, so like crying, or sometimes they have so many complaints. So the classical presentation we can't see because of the developing brain. This developmental status affecting the classical presentation confuses us. And the child behavior is a great source of distress to others, where the parents complain that this child is abnormal. They are not able to tell exactly what is happening, but they feel discomfort. So next is the distressing symptoms are part of normal development during the transition. Again, this is very, very important. If a child Like if your child cries during like the separation anxiety where the child moves to school during her early days, definitely the child cries. So this is normal. If the child going on continuously crying for the throughout academic career, then it is abnormal. So, and even the aggression during adolescence, this is quite common. So the aggression during adolescence is common, and we have to accept that, and we have to interact with both the parents and the child. So this is how where the normal transition from one milestone to second milestone is having some irritability or sometimes some regression. We have to accept that, and we have to convince the parents, and we have to educate the parents. So the this distressing symptoms are part of normal development, and we have the knowledge about that. And impairing symptoms in childhood tend to have an effect on the ongoing acquisition of the key developmental skills. So we can't see the development at one point, and when we go back, this may not be the classical presentation, but if you go, we have to identify the lack of development during that period. So the history and we have to be very, very patient in taking the history. And high rate of comorbidity. This is very, very important because almost 90% of the child psychiatry problems, they have comorbidity at some point. And especially if the severity increases, this rule is 100% applicable. So you have to look for the comorbidity. And second thing is when to say mental disorder. This definition I always, like whenever I am having a difficulty in diagnosing the case, I look at this definition and I try to stick to this definition. So with this help, I always try to diagnose the patient. So the dysfunction in the psychological, biological or developmental process underlying the mental function, this is very important for me, and this will definitely help us to follow the right track. And again, this overlap of the mood and behavioral symptoms across multiple disorders. So we shouldn't be like, should know how to separate the mood symptoms when diagnosing the patient, and the comorbidity we have to keep in our mind. So the treatment of child and adolescent disorders, again, so when after diagnosing, how to start? Then for this comprehensive evaluation to ensure diagnosis. So check for your diagnosis once, not only once, if needed twice or thrice. And if you won't get the treatment with whatever mode of treatment you are giving for a certain period, like you have to show some improvement within a span of 2 or 3 months, like that. You can't keep on going with the same medication or same type of treatment for a child for 2 or 3 years without giving much improvement. Then you are harming the child. You are not only making money of the child, you are ruining the life of the child. So you have to keep, like, when you are going to expect the standard guidelines and the standard guidelines for the medicines and for all therapies, they're showing us that at this time you are going to expect some result. So stick to that line. So if you are not getting result, go and check back your diagnosis. So working with school personnel, here we used to take history from parents or the caregivers, but even from the school personnel and from the school records, everything is important, especially in children group. And the treatment is both pharmacological and non-pharmacological. Here, sometimes the drugs take the lead role, sometimes the pharmacological treatment, non-pharmacological treatment takes the lead role. So it's like both are important. For milder cases, some are like they have good response. For severe cases, some are. So you have to bear those things in mind. We can't keep like this is only for this. We can't give such terms to the patients. So we have to keep both pharmacological and non-pharmacological treatment in mind. And individual, group and family therapy is also vital. And knowledge about the neurotransmitters. When we are treating the child, even the psychotherapy also, you should know what are the neurotransmitters and the neural circuits, the effects of the disturbances in the neurotransmitters and neural circuits causing symptoms to the child. So with that knowledge, we definitely monitor the progress of the child. And knowledge about evidence base for the use of psychotropics is the foundation for the treating clinicians. So, coming to the clinical issues affecting the response to pharmacotherapy, the comprehensive evaluation of for diagnostic accuracy. So, the diagnosis is ultimate. Unless you can't diagnose the child correctly, you can't treat. So, diagnosis is important. So, reassessment is needed if you fail to respond. So, we shouldn't feel low if our diagnosis is wrong. We have to check it once if we are not getting the good response, and we have to go back again and take the history clearly, and whatever investigations necessary you have to follow and see where the complaints are, like what are the factors that are contributing to the failure to response. So you have to see that. And knowledge about commonly occurring comorbidities is this is again important, like the ADHD and bipolarity, autistic and ADHD. So all these things, so we have to take care. And the medical conditions, again this is important, especially the gray area of the growing brain, especially in the first 3 to 5 years. The gray area where the neurological symptoms and the psychiatric symptoms they overlap. We have to understand the atypical presentations of both conditions. We need to assess, and seizures, endocrinal abnormalities, the hypothyroidism, the vitamin deficiencies, all these things, and the common viral infections. You have to take care in your mind, and you have to see for the medical comorbidities. And the knowledge about evidence of the first line drugs. See, the FDA has given what are the approved drugs and first line of drugs about all conditions, and you have the knowledge, and you have to better to take drugs from that criteria. And the psychosocial factors influencing the outcome of the treatment and the improvement. And the medication compliance is again important. Non-pharmacological treatment, as I said, it's a multimodal approach always. For a child case, you have to give multimodal approach, which is the lead role. Depending on the condition, depending on the severity, we have to decide. And the rating scales to assess the severity and the progress are important. Before starting the treatment, informed consent is essential. So you have to take the informed consent from the parents, and you have to tell them what is the purpose of your treatment. So you should know what are the target symptoms when you are treating. So what are your target symptoms in the, like in next month, what is your target? After that, what is? So the first target you have to fix when you start the patient. So you have to prioritize the symptomatology, and you have to assess the child individually. You can't dictate terms to each and every child in the same way. So you should know. So for certain diseases, hyperactivity is a must. For certain diseases, eye contact, so like that you have to, aggression you have to treat in certain times. So you have to prioritize, you have to keep the target symptoms. And the risk of treatment, when you are giving the medications, you should alert the parents about the risks. And this is also important, what are the alternative treatments, and including non-treatment. So if your patient tells you, the parent asks you, if I won't treat my child, what will happen? So you should know, you have to answer that question also. And even before asking by themselves, asking by the parents, if you are able to tell them, that is enough good. And unknown risks, this is one thing, because of the paucity of information, because we are frank, we are following the science. See, the long-term effects of a drug exceed, like the side effects, they exceed if the dose exceeds. If we are in the limited dose, most of the times we are safe. And definitely the disease, that disorder, is going to cause the harm. It is their decision to weigh the balance between non-treatment and the treatment. So like that you have to advise. See, if a ADHD child is not treated properly, he will definitely land into bipolar and the substance abuse, and not settling in the jobs, and the breakups with the life partners. See, all these are issues, and the suicidality. So you have to consider giving medication is better rather than not having all those side effects. You know about the non-pharmacological treatment, I did not tell you. And the first line of non-pharmacological treatment in milder forms of depression and anxiety, according to FDA and AACAP, and it is an adjuvant in ADHD and bipolar. Okay, social skill training in ASD. Here also, ASD is a different area where both are like they have certain. For the core symptoms, there are no drugs, but for the adjuvant symptoms, the drugs are effective. For the core symptoms, you have to rely on the psychotherapy. And Second thing, when we are treating the, because here the child with the drugs, the pharmacokinetics are important because the child is having most of the fat. So the drugs are lipophilic. Most of the psychotropic drugs are lipophilic. So they attach more to the body. And the CYP, the metabolizing enzymes are absent in the first year and they develop rapidly. So after that they need like the dosages are more. So because they metabolize more. So this we have to keep in mind. And the greater liver mass also. This is also because of the child's body mass is less when compared to the liver. So here the metabolism is faster when compared to adults. And coming to disruptive disorders, this is ADHD. And you know more about ADHD. This is one of the common neurobehavioral disorder where the role of drugs is extensively studied, right from preschoolers to adults. This is I think this is the only one disorder where from the 3 years to adults. So for every group is extensively studied and the FDA had given clear instructions how to treat the ADHD. And the one more thing is the effect size, means the importance of significance of the drugs with the response is much larger. This is 1.8 is good larger evidence, and this one is averaging around 1 is a great significance given to medication. So to treat a child with to treat the child of ADHD, drugs are the first priority. And the sad thing about ADHD is only half of the patients are treated. Rest are half of the children they never treated, and they they land into adult ADHD. Because of the adult ADHD, it is masked by other psychiatric disorders like the BPAD, substance abuse. So all these things are they dominate the picture of ADHD. So you can imagine the worsening situation of the child if not treated at his childhood. And these are the FDA approved drugs, means you can use safely. The stimulants, methylphenidate, amphetamines, the non-stimulant, atomoxetine and alpha-1 blockers, alpha-1 agonists. And stimulants, methylphenidate is available in India, amphetamine is not. These are non-stimulants are available in India. So methylphenidate, this is highly effective drug and rapid onset of action and comparatively well tolerable given in the dose requirement. Again, the large effect size is averaging about 1, means that you can safely advise the parents, and robust treatment effects are observed by FDA at different studies, and the approval dose is maximum of 54 in child and 72 in adolescent. And coming to the non-stimulant drugs, atomoxetine is again one of the important things, especially if the child is having problem with the neurological issues and tics. Then if the neurological components are present, then we can consider atomoxetine and the alpha-1 agonist. So I don't want to give so much details, it's there. Because these people are standing besides me, they are and the key studies, these people are bothering me so much. So,
we need to manage the time. That's our duty.
But you are bothering my attention also. So the key studies are the MTA, the multimodal treatment study of children with ADHD. This is a very long time taken. Like they have given 4 groups of treatment to 4 groups. That is medication alone, only psychological treatment alone, combination, and the community treatment. So the drugs that address the core symptoms of ADHD, whereas combined treatment address both the non-functional and the core symptoms. So best is combined treatment. Okay. So even this is substantiated by the New York study also. This MTA study is substantiated by the New York study also. You can see if you want to see the details. I don't want to give so much details. So it is there in the net. And in that they have studied the school children But here in the preschool study also, this is again funded by NIMH. Why I am saying this funded by NIMH means you can blindly follow that. So the NIMH funded study, this is preschool study. Here they have included the preschoolers, 3 to 5 age group also for the drugs, where they have they came out with the results that you have to give the lesser dosage compared to the school age children. If we give the lesser dosage, again the results are same because of the metabolism, slow metabolism in the preschool group. They can't tolerate the 1 mg kg. They have given 0.7 mg. So with that, you can safely treat the preschool children also. So with this, what we do, once you are able to treat the core symptoms of ADHD, the child will definitely adapt himself in the school environment and will excel in his studies. So you are giving life to the child. So if you give proper treatment and if you are able to correct the child fastly, the child is going to have a normal life. And the clinical recommendations, first is psychostimulant. If one is not active, go for second psychostimulant. And stage 3 is atomoxetine. Non-stimulant is the third choice. So like that they have given. And coming to the oppositional defiant disorder, this is also a type of disruptive disorder. Here the limited drug trials are there. They have advised multimodal approach with CBT as the first thing. And if needed, like the comorbidity is there, like bipolar, ADHD, anything, then you have to treat with medications. The first choice is psychotherapy for ODD. And the conduct disorder also is the same thing, psychotherapy with mood stabilizers and atypicals. Coming to autistic spectrum disorders, nowadays I think we are seeing more of autistic cases. When we started my career like 10 years ago, now I am seeing more cases of autism, and especially after the COVID era and with the COVID era, where mothers, how they don't know how to handle their children, and they started giving the iPads, and after 1 year they realized that my child is not even looking at me. So with that complaint they are coming. These atypical cases are, why I want to stress is, this is not the true autism case that is described or in the textbook. Here the genetic component susceptibility is there, but because of the environmental conditions, the child has landed into autism. So we can address the problem effectively. These atypical cases can be addressed effectively and we can get the treatment fastly and completely. So at least we are enough lucky to treat the child fastly. This is the prevalence is 18.7 per 10,000. And the core features, the impaired socialization, communication and behavior. The associated features here, why? Because the core features we didn't have any treatment. So depending on the associated features and the intelligence and the family support, the outcome differs. The outcome changes. Like if you treat the anxiety, irritability, hyperactivity, we can reduce the severity of the impairment. Okay, so there is difference in the core symptomatology and the severity of the presentation. So maybe we are not able to address the core symptoms, but we can reduce the severity. At this point, I would like to say one series in Netflix, that is Good Doctor, where the autistic doctor, it's a very well taken, what is that? Like how they portrayed the autistic child to a better, best doctor, to be frank, and how it has helped him to gain his knowledge in all things and correction the core features also. So that's how he has improved. So if possible, try to see that Good Doctor. It's a very good series. And no medication effectively treat core symptoms. Associated features like I told these can be treated and definitely they change the outcome. And risperidone, aripiprazole are the FDA approved drugs to treat irritability. I gave that line because the psychotropics at that age will definitely be pointed out by the parents. So we are giving psychotropics at this age. So this is how we have to advise them. And the key studies, again, the risperidone trial and methylphenidate trials are there to support the FDA thing. Coming to mood disorders, the major depressive disorder, the same criteria as per the adult. But the thing is,
Madam, studies are not required for them.
that's what, sir. I didn't say
Please.
much about it.
Right. It's just simply me.
Same criteria as adults, but here the irritability is more important. If the child is irritable and his functional domain is impaired and he's not with the parents as in the same way previously, then you have to consider. If it is persistent, I told you the criteria you have to follow, the time frame you have to follow, everything you have to follow, and so, and after that, you have to consider the severity. For milder cases, the psychotherapy is first line of choice. But for the moderate to severe cases, you have to depend on the drugs where the fluoxetine is recommended. And the relapse rate here, why? Because the relapse rate is 30 to 70%, and continuity into the adulthood is 100%. It's more likely. So the AACAP, this is American Association of Child and Adolescent Psychiatry. It has recommended psychotherapy for mild and uncomplicated depression, where the severe and chronic or recurring MDD require pharmacotherapy alone or with psychotherapy. This psychotherapy in severe and moderate cases, they identify the relapse patterns and to shorten the length of the episode, and also to some extent it prevents the relapse rate also. So that's how both are important. And this is STATS study where it has advised fluoxetine, weekly CBT, combo pill, and good response with fluoxetine and CBT. So the combination is good with both. And one important thing in bipolar and mood disorders is the suicidality, where it is the third leading cause of death in adolescent. So I think I have given. These are not important. See, this bipolar, again, the diagnosis is controversial because of the ultradian and ultra rapid cycling. So you have to see, and again, here the diagnosis and the DSM criteria for the mental disorder in child. So again, that takes our hand to treat the child. So with that, we have to see the comorbidity also. The ADHD, conduct, anxiety, substance disorders are comorbid with bipolar. So you have to consider treatment. Here, if you suspect bipolar, treatment is drugs are the first line. Psychoeducation is adjuvant. So you have to treat the child. Atypicals and lithium, these are important. And suicidal, I want to stress this. Why? Because if you won't treat the mood disorders properly, suicidality is the important side effect, especially in the adolescent age group. So 90% of the suicides associate with psychiatric illness, and 90% of the suicidal attempts are also associated with psychiatric illness. So if a child expresses suicidal attempt, wish or suicidal attempt, then you have to consider for treatment. And this 35 to 50% of the depressed children have made or will make suicide attempt. That's what the AACAP recommends. If you use drugs, there was a black box warning for SSRIs where the increase of suicidality, but now the recent studies have shown that there is decreased suicidality with SSRI usage. The other disorders commonly are the sleep disorders where there is no FDA approved drug. You have to consider the psychotherapy where the sleep hygiene and everything. And melatonin is recommended nowadays, but still it is not FDA approved. Enuresis, etiology is important where it is primary or secondary. If you know the primary cause, you have to treat the primary cause. If no other cause is there, only psychological there. Again, there are two options, desmopressin and imiprapine. And comparatively, imiprapine has much evidence. And stick disorders, again, this is also, treatment is not necessary for medical reasons, but for the cosmetic purposes, we treat the child with atypical antipsychotics with very mild dose. Coming to anxiety disorders, again, here, anxiety disorders, this is OCD. We have to treat with both, you have to treat like the psychotherapy and the drugs. And PTSD also, psychotherapy is superior to SSRIs. So first the PTSD, you have to give the psychotherapy. Other anxiety studies, they have the same CBT for milder cases, drugs for the severe cases. And last thing is schizophrenia. Again, this is the age group is important. 13 years is the age group. So after that, if you see the psychotic symptoms, you have no other choice giving a typical antipsychotics. You have to reduce the psychotic episode with drugs, and the psychotherapy is for social skill training and adaptation into the society. So both are important. So unless you reduce the positive symptoms, you can't keep the child in the society. Substance abuse, okay, 90% have comorbid, you have to treat, and you know the importance of psychotherapy in substance abuse disorders. So once you start medications, what are the long-term monitoring? How to monitor? You have to see the weight gain, you have to see the metabolic syndrome, all these things you have to monitor. And the hyperprolactinemia you have to consider. And finally, see, ultimately the psychological development and the brain functioning is important rather when you weigh between brain and body. So if you see the Stephen Hawking, he is a man of inspiration for next few generations also. He's an outstanding example for such things. So it is our duty to keep the child into that normalcy. So with everybody's help, both the psychiatrist and the psychologist's help, the child definitely have the normal life, normal smile. With that, I want to put an end to my presentation.
Thank you, madam, for your holistic and extensive presentation regarding the drugs, and madam covered all the things from the beginning of the common doubts, common symptoms, and distressing symptoms, and madam also covered comorbidities, which is very, very important in child psychiatry, comorbidities. And history taking is very important, and from the different sources, from the parents, teachers, friends, neighbors, everything. From every source, we have to gather history in the child psychiatry regarding the children's problems. And madam also covered all the disorders, ADHD, conduct disorders, oppositional deficiency disorder, and autistic disorder. Regarding all the drugs, madam covered. And if you have any doubts, only few doubts, you can ask. Audience, any? Please.
Thank you for the presentation, ma'am. What is your experience with using stimulants and non-stimulants in less than 6 years?
I always try to start with non-stimulants.
Less than 5 years, because I told you, it's gray area. So you have to be careful about the seizure cases and other developmental problems. First, I'll start with the non-stimulants. After that only I'll consider stimulants.
From what age do you put on?
Definitely from 3 years.
So, I have been noticing that the CBT has been mentioned several times, especially with children. So, how successful is CBT with children?
Ma'am, this is again it's like the modifications will be there, including the parents and the school education, and it's like again tailor-made. Like you have to take the child into consideration. What are the target symptoms? Which is the provocating factor for that?
I'm not talking about adolescents or.
No, I'm talking about the child. So again, here what is the problematic behavior? We have to identify that part only, and you have to take always consideration. CBT is mainly for the parents for me first. So with that.
With parents, because children's
It's only about the parents. Mainly parents.
Yes.
What may I ask that? I just have one question about the field in general. I'm a psychologist and I want to know, is child psychiatry training different from regular psychiatry training? In the sense that how do I know which psychiatrist to refer a child to? That's always a challenge in our city where parents will say, who's a good child psychiatrist? What is the difference in training there, ma'am? And sir,
You know the difference between cardiologist and general physician.
right. No, but ma'am, we were talking about a regular psychiatrist who treats patients versus child psychiatry is more advanced training, you mean, than a regular
Definitely.
psychiatrist.
You have, but you should have interest.
Okay, that's what I'm asking. There is additional training for child
And
psychiatry.
for a psychiatrist or a psychologist, whoever, because you are dividing the symptomatology between the psychologist and psychiatrist. But the problem is for the child, you are dividing the
No, ma'am,
difference.
my question was.
I am telling you the answer. So, to treat the problem, you should have the normal development knowledge. You should have the knowledge about the normal development. Then you have to know about the abnormal development. There, the difference comes.
Thank you, audience, for your questions. I think most of your questions are answered by Madam. Okay? So we will stop the session. Thank you very much.
Sir, I request sir to felicitate ma'am.
He's my teacher in
Now I request Dr. Rishikesh Giriprasad to chair the next two sessions. I would like to invite Dr. Pooja Jha, founder director of Total Solutions. She received doctorate in psychology for her research on early cognitive interventions. She's a mother of two lovely kids. She would be presenting the next presentation. You will see how the ADHD presentation is going to be.
I think she said
In the
it.
sense, the person who has ADHD.
She said it. Finally, the mic comes in my hand. You all are grabbed now. Okay, so because she already said ADHD, I cannot stand at one place and make the presentation. Allow me to move around. And all those who are seeing me online, hi to you all. So, thank you, sir. I will be quick because when ma'am was giving the wonderful presentation and she was going 1 minute extra, I was cutting 1 minute extra from my presentation. Okay? Yeah, we should do that because I consider you all as me. We should understand. Now, we will talk about assessment and all, but I want to go beyond this SLD, which has become a very fashionable term. We say dyslexia, dyscalculia, and so on. But please, learning difficulty doesn't stop right over there. We have to take a little broader perspective so that we can do what we are here to do. Please remember, in a regular classroom, all of them, they are sitting. You need to do a good differential diagnosis when you are meeting them. It is very sad to know when a child comes to me at the age of 15 years and mother says, I diagnosed him at the age of 3.5 and still why my child is suffering so much. And when you do your analysis, you go through all the reports and everything, you come to know, oh my God, diagnosis was not right. You kept on treating him for something else, but he was not that case. Can we go and get back those lovely 12 years from my child's life now? We cannot. We will keep on cribbing that somebody didn't help me. Mother is happy that, oh no, I diagnosed at 3.5. But please, we all who are sitting here, those who are in the field of this practice, please ask yourself, doubt yourself, do 101 analysis before saying that this child is having this issue. So a parent comes to you with a child saying that my child is not sitting in the classroom, he doesn't pay attention, very, very poor interest in the academics. And what we start doing, we start talking about dyslexia. Maybe he's having learning problem and so on. Please consider that there can be many other root causes which can result in the same symptom of disinterest in academics. You can have a child who is ADHD, not sitting at one place, not paying attention, making careless mistakes, and so on. That DSM-5 beautiful list. You can have borderline intelligence in your classroom or who is coming to visit you. Beautiful handwriting, can read, can write, no spelling mistake, but doesn't understand what is he reading, what is he writing. So again, a teacher says that what should I do with his beautiful handwriting or his good attitude of learning? Because he doesn't understand. He is failing in all the subject. Assessment comes to play the role. Specific learning disability, very intelligent, orally can tell all the answers, but when it comes to writing, hesitant, making silly spelling mistakes, not able to read, hesitant when you ask them to read, can say the letters but cannot blend them together to say the word. Somehow I feel that we all get so much bugged up with their problems related to education, we don't realize that a human mind is also sitting in the same body. So it's not about academics. Try to look beyond that skill which you are testing. Try to see that cognitively, emotionally, is the child feeling all right or not. Autism spectrum disorder, another condition, very common nowadays. I think we are listening since yesterday about it. I feel that again, this set of children are also sitting in our classrooms. They are also coming from a teacher's referral, where maybe he is high functioning, can talk, but not able to relate, not able to connect, feels lost. I saw a boy recently who is 15 years plus, and he told me so clearly, Pooja auntie, can you teach me how human being thinks? I'm not able to connect. What do they want me to talk to them when I sit in the group with them? And I said, yes, looks like I can teach you. A child diagnosed in US with autism spectrum disorder, taking all the treatment plan, good improvement, had tears in his eyes, and because I had same Gayatri standing behind me in the clinic also, because it was not now the time to go out, go away from the center because everything was done, and I love to talk to them in the waiting area. So he just looks at me and he says that, yes auntie, I think I want both of you help. Why? Because Gayatri evaluated him and I was the one who was doing the last part with him. So they have emotions. Maybe we have to make them aware about theory of mind. Social pragmatic disorder, another set of children, very intelligent, too good. I think till their 4th standard, everyone is kind of, oh no, he doesn't have any problem. Just that, he's weird. He doesn't talk the way, other kids are talking. Like one of my boy, Pooja auntie, tomorrow is my birthday. Will you come? I will come. But which cake are you planning? Chocolate cake. Oh no, I don't like chocolate cake, John. I like only pineapple cake. And the child is not able to understand that I am joking or I am creating a kind of just a small fun. He would tell his mother immediately, Mummy, cancel chocolate cake. Pooja auntie wants only pineapple cake. The kind of robotic speech. Watch for everything. I love this set of kids because when you work with them on theory of mind, teach me language module, they are doing beautiful. Their main issue is about language processing skills. They are finding it very hard that how these humans, they can say something, but they mean something so different. So different. So if I say, okay, Manjula ma'am, please come to my home. Manjula ma'am will never come to home. She will say, you were so mean while inviting me. But these babies, no, she invited, we must go. Okay, we have to go there. Like small kids, so-called regular kids. And then, when they reach to their home, no matter how many clues people are giving, go, I'm getting bored now. I have so much work to do. Just because you are sitting over here, I cannot do. Child is least bothered about those clues. Don't you think that some of us also don't take clues? We don't take clues, correct? We must take that. We must take that. Okay? Emotional behavior disorder. Actually, I'm so much happy with COVID because I got a chance not to work or work from home or be with my kids. I really love the way we could spend time talking to each other, cooking all those dishes. But yes, it's true that emotional behavioral difficulties are coming up more and more after this pandemic period. Maybe some of us, we didn't know how to use this time. This can also affect your learning ability. Okay? So one more case. He is right now 16 years, same child about whom I said that at the age of 3.5 got diagnosed and everything. He has a very clear history of trauma. Father had severe asthma. He couldn't work, without oxygen support. He used to go to office also with oxygen support. One day he got a massive attack and he died right in front of this child. Child could not digest that. In fact, trust me, mother has also not done any kind of grief counseling for herself. She has also not come out. All this happened about 12 years before, and this child is intelligent. So yesterday we did, his whisk because the school says, no, we have to get some help from international board, we need to see that, what can be done. 1-to-1, reading age, above his age. Spelling age, above his age. Processing, so good. Comprehension of equivalent to 18 years old adult, young adult. Okay? Why is he not able to perform then? Because the minute you create a small stress for him, he becomes blank. So as a psychologist, did anyone work on that part? No. He was so young. How can we refer to a psychologist? We kept on referring to remedial therapist. What remedial therapist did? Speed writing, speed copying, how to work in the distraction also. Sorry to say, could not help my child. My child is still good on 1-to-1, not able to perform the minute he is in the group. Intellectual disability, yes, we need to evaluate that also. We do know that many of these children are also coming to our school setup, and we have to ensure if they can get some of the academic skills and importantly their adaptive skills. What are we trying to assess? Is it the academic skill? Is it the life skill which you want to check? Is it the prerequisite to learn you want to check? Or do you want to check the sensory aspects of a child? Another one very important, I consider sensory integration or sensory skills as pre-primary factor, and I try to take care of it only through play. Only through play. If child can play nicely, you don't need any occupational therapist. You don't need any psychologist, and sometimes no remedial therapist too. If a child comes to you between the age of 3 to 7 years, please, there are some options available. NIMHANS SLD Index has level 1, which you can use. We have Brigance Learning Inventory, very good one, quick 24 skills. You get idea about child's language processing, child's cognitive skills, communication skills, and also their early academic skills. Another very good one, NARBOR Learning Inventory, beautiful test, very beautiful. Any teacher, any psychologist, any special educator can use. Yes, NARBOR Inventory is a little lengthy one, but it gives you all the details about a child's learning ability. You got a child at between the age of 8 to 12. So please, before I move on to the next one, if you have got a child between 3 to 7, please don't start working on writing. Don't start working on reading skill. Please don't do that. Check. Is the child playing? Even if he has just learning problem, is the child playing appropriately? Is the child able to do his age appropriate adaptive task? Can he brush his teeth? Can he take bath? Can he wear the dress? Does he know his right and left? Does he know how to make the dress in the correct position? All of that you need to check. Work on the potential error areas. Don't work on your surfacing symptoms, because this is a beautiful time you can do a lot of correction. If it is between 8 to 12 years, still 50% of attention should be given on the causal factors or the potential errors, and then other 50% you can work on whatever is the surfacing, because I want my child to adapt in the school, because the child is not going to stay with you in home for the whole time. Child is here also to get that one remark from the teacher, good job, wow, you did it, you have done half of the classwork today. We want even those remarks. NIMHANS SLD Index Level 2 can be helpful. TAPS, Test of Auditory Perception Skills. Many of us, we kept on getting mesmerized by the visual perception skills. No, auditory is equally and very, very important. Okay, it's a myth that specific learning disorder will have majorly and only visual perception problem. No, they can be sometimes too good in visual perception, but auditory is affected and language processing is affected. Diagnostic test of learning disability, another very good one, very, very kind of popular. It has 10 subtests. Again, this test talks about mainly the potential error areas. You can evaluate that. Shonell's reading and spelling, by the way, they are also part of NIMHANS SLD Index. So you can use these two tests. Intelligence tests like brain-based intelligence test, Mallin's intelligence scale, and Wechsler's, all these can be very good one to know the IQ of the child, because if you want to diagnose SLD, still in India, we are following the older criteria where we do the IQ. By the way, in abroad, no more IQ assessment is required for diagnosis. They have already covered even borderline intelligence for dyslexia kind of symptoms. But in India, we are still following a specific learning disability only, no disorder, because in government gadget, we have that term. Age 12 above, now the rosy picture goes away a little bit. You cannot be so ornamental that I want to work on the potential. He doesn't know, he doesn't know reading, so I will work on phonics. Please don't do that. Children, they feel very funny that why am I being taught A for apple or A says app? They are not able to relate with that. It would be great if you can start using some other methods, use child's curriculum to intervene with their difficulties. Purpose of assessment now changes. We want to get exam accommodations by CBSE or ICSE or from a state board. CBSE and ICSE, you just have to be an RCI certified psychologist. You can do evaluation and send the papers through the school. As an individual professional or as a parent, we cannot. But if you are sending your papers to school, school is supposed to send that. For a state board, we cannot send. It has to be by medical board. So, sir, like Rishikesh sir and all, they can actually make the certificate for a child who is studying in the state board. Trust me, the awareness is so poor in the state board schools that we don't have many of them availing actually these kind of services, especially for dyslexia or any other learning problem. I will not go through this. This is too huge. Don't want to take away your time. Again, I will, whatever WhatsApp group we would have made, if I'll send you this. These are the early indicators how a small kid can be identified that he or she might be at risk of developing any kind of learning problem. Please, I'm not talking only from the perspective of dyslexia again and again, because not very important. We need to see that what kid is suffering from and how we can remediate, especially at the early stage. After that, we can do specific diagnosis according to CBSE also grade 3. We are supposed to do proper IQ and proper educational assessment to certify a child. Next. This is for little grown-ups, that how in reading they can do omission, they can do addition. So like if the word was hut, the child says ut. If they substitute the sound, it was basket and they say basket. They can do substitution, they can do skipping words, line, specific word, crowded blackboard cannot blend the word, and so on. List is in front of you. Let's pay attention to the main thing. Even if you do a very simple test like color progressive matrices, people are aware? Okay, CPM, SPM, even while doing that, be alert and agile. Okay, keep looking at the child's eyeballs. How is he tracking? Does he do any kind of random selection? Is he impulsive? Is he totally doing trial and error? Is he systematic while doing that? If you can write your observation on a simple screening tool like this, you can get the whole knowledge about all these errors and you can work on it. There are multiple intervention plans which you can start utilizing for the child. I will talk about only one test. I'm very selfish because I have made that test. Okay, not me alone. We have a big team. Very lucky to have Dr. J.P. Das, who is a renowned psychologist, as our team leader. And being a very patriotic psychologist, he wanted to do something for India. So this is the latest test published in 2020. We have collected norms on 1,700 children across India. And then for special need population, the whole work was done in AIIMS, Delhi. And we have norms even for them. I will not again go into detail of this also. We'll send you this slide. You can go through. We have 15 assessments. The fast track version can be done in 45 minutes and the detailed one can be done in 1.5 hours. This test is for the age group of 5 years to 20 years. For geriatric population, the sample is still getting collected. We have verbal, we have non-verbal speed and self-regulation. So one test which can give you the knowledge about ADHD, knowledge about child who is having learning problem, child who is having any kind of traumatic brain injury. Epilepsy protocol can be developed on this test and you can have more knowledge how the child is performing. Of course, because it is from J.P. Das, sir, there is a lot of neuropsych assessments involved in it. trace. I hope many of us we know how we connect the numbers in order without lifting our pencil, and then the child should not retrace. So this test also we have developed the norms for our Indian population. Next. Plan pattern. Here the numbers are given in each box. The child has to arrange from small to big, not using the finger. Eye tracking. And then we ask the child what pattern emerges. You need to say that. If it is Z or if it is N, child is supposed to say. Exactly the same thing we will check for reverse also to see how much of inhibition control child has. So here, if it is Z, then the child says N. If it is N, child says Z. Visual search, another very important visual figure ground perception test. Here the child searches the target number and we note down the time taken. One very interesting test again for self-regulation check. Here 4 dimensions are given, shapes are plus and box, and colors are blue and red. We give the practice for color first, we give the practice for shapes, and then comes the real test. On top of each one, either it would be written C or it would be written S. If it is S, child has to inhibit and say the shape. If it is C, child has to inhibit and say the color. He cannot say whatever comes first to his mind. Purple is troop. I think many of us, we already know the color is troop test. We can pass on this. Here the number is troop. If any number which is more than like 5, 6 and 7, you are supposed to say big. And if it is less than 5, then you are supposed to say small. It will again come in 3 versions to check the inhibition control. So it will come, the actual small number would be given in a bigger font and the actual bigger number would be given in small font. Just to see, is the child able to inhibit the appearance but say the actual value of it? I already said. In vigilance, we will stop here. Vigilance test we mainly use for the visual acuity. So here the numbers would be displayed on the screen for the child and the child has to tap on the target number. Number span and the sentence span is new of its type. Here we say the sentence to the child and we ask them that you need to tell me whether it is true or false. Okay. So for example, all mother goes to office. No. Sky is blue. Maybe the child would say yes. But the task is, child has to remember the last 2 words of the sentence. Office and blue. Same way for the number. We say simple equation 5 plus 1 equals to 9. No. 5 plus 1 equal to 6. Yes. But the task is that the child should recall the last 2 digits. I said about it. We already know that rapid automatic naming is very important. We check that also in this test, especially when you are suspecting any kind of dyslexia. Predicament, another very good subtest where we try to check on the social problem solving skill of the child. Okay. In this one, we check about the visual spatial relation, whether the child knows that or not. So we give different pictures, different positions of animal and we ask the child with a different statement whether it is true or it is false. I think enough about even BBIT. So this slide is also too big. I can spend, I think, 3 months on this. Intervention. What do you do when you have understood that the child is having some kind of difficulty? In cognitive area, you do work on visual perception, whether it is visual figure ground, visual sequencing, you have visual similarity, discrimination. List is very, very long. Okay. But when you identify that yes, child is having visual issue, you do pick up and for younger kids especially work on the potential error area. Auditory perception. Very simple activity like you clapped and the child counted and said you clapped these many times. That itself will improve their auditory sequencing. You can do many other things. Give them a letter cancellation sheet and say whatever number I dictate or whatever letter I dictate, I want you to cancel that letter or that number. Kinesthetic perception, movement related sensation. You can write at their back and the child actually tells you what did you write. Blindfold the child, make them walk on a letter which you have written on the floor. Take them to the board blindfolded and ask them whatever you walked upon, can you please draw that on the board? Very simple but a very beautiful activity which can be used to improve the kinesthetic perception. Language processing, for example, if I say, I am made up of wood, I am cylindrical in shape, and I always wear a happy birthday cap on my hat. What I'm talking about? I can become small, I can become big. No, I cannot become big once I become small. So much complicated, no? Pencil. I'm made up of wood. I'm cylindrical in shape. I am conical on top. I do become small when you sharpen me. So, language processing, I gave you a very complex example, but you can begin with very simple thing. You can just ask the child to describe an object. You can ask the child that, okay, this is the object. You just talk about all the shapes involved in it. You tell me the words about the object, but the name should start with letter L only. Okay, so simple to complex. You can work on planning by giving them lovely mazes. Working memory. Working memory is your capacity to hold the information until you solve it and give me the answer. Okay, so if I say plant, floor, fan, table. Plant, floor, fan, table. And I ask the child, tell me the first letter of all these 4 words. You are working on their working memory. Correct? If you say, tell me all the vowels in the same order. Your free gift is working memory, and along with that, you are working on their sound. You are working on their word analysis. They would know so much more about this. Attention span, of course, a very difficult one. I do believe in medicine a lot. Please, psychologists, dear my colleagues, if you feel that my efforts are not responding, don't hesitate. Do refer to a psychiatrist. Take their help. They are like Adi Sheshama madam showed one picture no, of the tiger. They are really not tigers. They can really make life much more beautiful. In education, you have to work on reading and spelling abilities. Alpha to omega methods are very good. Please, you can read about that. Don't go by only phonics. Many people, out of their interest, they start learning phonics. Please, phonics is not the answer to your spellings or to your reading. Okay, they are important, I'm not denying. But if you see a child is struggling, don't keep doing phonics. Immediately shift your method. Go for your sight-word approach. Spelling rules are many, you can use them, but don't expect that the child would remember in the class. My teacher told me that C says curve and it is followed by A, O, U and R and L. So now today my teacher is dictating me a C word, I will remember the whole rule. Is it easy? No, it's not easy. Teach them rule, give them the practice from their own curriculum, but do not expect that this is the ultimate answer. Do create a support system for the child, very, very important. Handwriting, sentence writing, math skills, comprehension skills, study skills, very, very important when you are doing intervention. Behavior, you need to use behavior modification. Child has gone through a lot of negative experience in his life. Teacher said, you look intelligent. I think just to trouble me and your mother, you are not writing. He has gone through a lot of negativity. Do work on certain simple behavior modification skills to boost their motivation, their confidence level. The other 3 are for children who are having very mild autism or social pragmatic disorder. For them we can use. Motor, very important because they have very weird or difficult eye-hand coordination or the pencil grip. A good occupational therapist can help you. As you know, I'm very, very smart right now. Yesterday I could not present my research paper, so I will take 2 minutes again and finish this also. Okay? So we have done this research which got published in 2021. We had data of about 2,000 children on missing. I think I could have even developed new norms with that, but I didn't do. But you know, when we started doing data cleaning, we had only 332 which we could use, okay, based on our criteria. Basically, when we did the data analysis, we saw that actually, yes, for dyslexia, we still found that some more kids had visual perception difficulty than verbal. But please, clinically, I'm telling you, it doesn't happen every time. It doesn't happen every time. Children who had ADHD, they showed us more difficulty. ADHD and with diagnosed SLD, they showed us more difficulty in the working memory. So, I really started when I'm practicing my intervention, I started doing one thing. Even if a child with ADHD is showing me all the symptoms of dyslexia, I do not work on dyslexia protocol. I still pick them up for attention enhancement, and I change all my strategies around their inattentiveness and their impulsivity part. They are doing very good. So in my experience, why experience? Because that research paper is not published yet. In my experience, their rate of recovery is beautiful. They are doing excellent if you are trying to use proper medication, your strategies, creating a support system in their school, very important, and counseling their parent that what kind of monitoring they can do at home. Okay, thank you so much. So, any comment on?
Thank you, ma'am. That was a nice, crisp, and fast presentation. I don't know how many could get into their brains, but the things which you have told are very, very important. Most of the things like basic focusing on phonetics. Most of them do it right when there is problem with this. Focusing on phonetics is the most common thing usually people do or the therapists do, which is probably not right thing to do. And shifting the child who is able to talk, who is studying in a 10th class and he wants to go out and learn phonetics, will definitely harm his self-esteem.
Yes.
That will be a big problem again to deal with it. So that's why these things are little helpful, more than helpful, not little helpful, and implementing this will definitely do. Before giving audience a doubt, I have few doubts, ma'am.
Yeah.
So there is no particular guidelines for assessing SLD. So everybody has their own scale of assessing SLD.
Okay. So there is a guideline, sir.
There is somebody assess SLD by enhanced SLD index. Somebody uses WISC and somebody uses MISC. So, but as per the certification process, so which is the one which has to be done?
According to government gadget, it has to be either MISC. By the way, sir, they don't even know about WISC.
Yes.
But yes, when we put in the description, this is the Indian adaptation now. So then they accept it. And enhanced SLD index has been accepted.
Yes.
That has to be done. But in enhanced SLD index, there are many subtests which many of us, they won't even have the access to. But boards, sir, as such, they are accepting if you are doing Shonell's reading, which is a part of enhanced SLD. Their maths test, they are accepting it. Their spelling test also, they are accepting.
So the individual test can be done and grouped into and given a report.
Yes.
And before that, as you said, Western countries are not giving importance to IQ. But in India, 85 is the cutoff point.
Exactly, sir.
To serve, give a SLD certificate. And
yes,
most of them, what I get referrals are, the child will be having IQ of 80 and they will be having, the report will be child reading and writing difficulties. So please keep those in mind that
they are not accepting.
They are not accepting. If
CBSE is not accepting.
If IQ is 85 only, then the child can be SLD certified. That is mandatory for that. And
so CBSE is now also giving help to children who are having IQ below 70 by 100.
Yes.
Yes.
The marks,
but unfortunately,
the marks percentage, borderline people, they are getting benefits. But whom to give scribe, whom not to give scribe is decided by the psychiatrist sitting there. And you can only mention what are the problems that can be faced. But I have seen certificates that give him scribe, let him give permission to get a calculator and all those things. That doesn't work like that because my job is at stake. If I give certificate something like that, in future this is going to be verified. Previously, we used to give certificates for intellectual disability kids for passes and bus passes. Now they are coming for verification now. This is your sign or not. So if I am giving certificates in and out like this, I will be in soup.
Very true.
So the psychologists who are doing those assessments should clearly tell them that your child is borderline intelligence. You can't get reading, writing certificate, SLD certificate, but you will get some benefits.
Sir, in CBSE they don't get any, by the way.
At least extra time I'll give it, ma'am. I'll tell borderline I can give extra time. 60 minutes of extra time I can give it. They come for only scribe.
Yeah.
Most of them write that they come for only for scribe, which is not your decision to make primarily, not to hurt you guys, to make you understand this. Not your decision to make what gift scribe should be given or not. Not this is not. Based on assessment, it will be there. And there's a lot of confusion in your tests also, whatever you do. you do whisk, you do many things and all those things, and group them in one whisk result. Whisk result you do, give one impression, and after reading you give one impression. Rather than doing that, give whole impression at end. Because this will also confuse. I can understand it, but this will confuse the board member who doesn't know anything about it. Here the IQ is less. Here the IQ is. If verbal quotient is at an 81 and other quotients are better, overall he is above 85. Again, he points out that question only. Why is native? Why can you give it? So that's why there are so many practical problems going on. So if you are doing that, probably you have to do it in a particular way, and overall impression is pretty much important.
True. But the only thing is that even for a scribe, we can suggest as a psychologist. Only thing is your reasoning has to be appropriate. You should definitely see what is the block design score, how is the child's grip. If you are giving your reasoning, definitely a psychologist can also suggest.
I get children with multi-intellectual disability for scribe, ma'am.
So they can get, by the way.
But they can't get scribe unless they can say. They should say.
Correct.
The ability of testing.
For multiple one.
Ability of testing should be assessed in those cases, which is not assessed. And they send come for scribe, which is difficult for.
Which is very difficult, very true.
And they'll be sitting on as you guys will be saying that you'll get a certificate, go and show this. They come and sit on my hands, give me a certificate. My psychologist said that you're not giving certificate.
You are not giving. True.
So please keep this in mind.
Definitely in assessment we all have to learn a lot, including me. There are still many things. Yes.
Yeah, I just have a question since I go through this work and I refer everything to you. Thank you for that. That was very, very useful and helpful. I'm curious. This area I've always been wondering about, the borderline intellectual functioning, right? The between 70 and 85. What is available to them? Because I end up seeing the kids when they are 19, 20, and the parents say shadi karani hai. They come to the house.
Yes,
right. And so that's the struggle, and I always wonder what is available to them.
Sorry. Legally, nothing is available to them because they are not coming into that intellectual disability. Right. They don't even come into SLD. Right. Actually, nothing is available.
So I'm right to assume nothing is really.
Yeah.
Nothing
is available.
That has to
State board, sometimes they are able to get that.
They can be put into a slow learner group and can be given extra time for 60 minutes and ignore spelling mistakes.
So now a lot of system errors.
But the systemic issue is beyond after school. We are talking about academically. After academics, what happens?
They don't even get disability certificate.
Right, that's the problem.
They don't get.
Is it a huge systemic issue there?
Huge.
Okay.
This is not the platform, but please, I have been to CBSE for one huge documental error which they had made. And they are now so ruthless that if it is 69 or low, you ask me. They were asking us for dyslexia, give us, VSMS score. Violent social maturity scale should be given. Why should I give for dyslexia? They will be always average or above average. They are good in adaptation. But people, those who are sitting there, they don't understand this part. Yes, that's a very, very painful situation, Diana, no doubt about it. And, at least till pre-pandemic, by the way, they were giving all benefits. Maybe because they were not going through the papers or what, they were giving all benefits. One person came and made the whole change, said, no, in the gadget it is not written, we will not give. So now borderline is not getting anything from last 3 years. So sad, very sad.
Borderline getting sent into Nilofer, and I'm definitely giving them some concession about reading because.
And then when you send to CBSE board, they are.
CBSE won't take it, ma'am. State
I'm talking versus CBSE
won't take it.
CBSE is not.
And one.
We will have that discussion in another conference. That's a beautiful topic. They can cope up, by the way.
They can cope up.
Another conference for that.
Can we please have the discussions later?
One more.
There is last thing to be added. Once you have diagnosed SLD, please suggest them remedial education or special education, something like that. You don't depend on certificates, please, because certificates are given till professional courses now. Previously till 10th, now till 12th, now professional courses.
IIT, one of our boy has cleared only because of one simple certificate. So intelligent he is, but cannot read cannot write.
So the problems they will face in future while they are doing job is pretty difficult. Have clients who are with depression and anxiety, who have specific and desire coming to me say that my younger one is working better than me, sir. I can't do mathematics, and I'm a team lead. I'm not able to explain them. They go into depression and anxiety because of this. So along with getting certification is not the main criteria. How to make the child pass. It's remedial education also.
Life picture is very larger.
Yes.
These are very simple.
So don't just focus on one thing. It's a large picture. You have
Very
to
true.
focus on treatment part also.
Yes, very true.
We had a very good discussion and a lot many take-home points.
Mamta,
Can we
talk
please?
on phone about your question? Acha, okay, ma'am, yes.
As we're talking about testing and all that, assessment, there might be situations where this goes wrong.
Yes.
Right? Like I'm working with a student, we know very well he's good, only important.
True.
He just says name, try, aim, test out.
That's what I'm saying. That be very very careful before these are the weapons. AK-47 in your hand. Don't kill people. Okay? Don't kill people.
For everyone.
True. And please, Mamta ma'am is one of our very senior most professional. I think we must listen to her. Thank you, ma'am, for adding that point. Now, taking away. Thank you so much, sir. Can we do that formality of taking the prize little later? Thank you, sir. So, we have one more research paper. It was very sad to see that to evaluate adaptive skills of children with autism, when we were trying to see Indian research papers, very, very few. I think Gayatri, hardly 2. And third one is ours?
Not only two, only one.
Only one. So, we are very lucky to announce or proud to announce that second one is our research paper. We will quickly present that paper also. And Gayatri will do the honor. GV and Gayatri is the head of our research department at Total Solution Rehab Society.
Madam.
Yes,
So it's the yesterday evening's paper presentation. Gayatri, we can give you only 5 minutes, please. Try to finish it up. Mike, podium has
In the last week, they can do it, right?
Sir, actually, what was happening that yesterday they could not because the whole session went late. So they told us that with this you finish it up.
But today evening you can.
So, Gayatri,
I'm not doing
please.
anything out of my choice. Trust me.
We will just finish it off. 5 minutes.
So I won't take much time, sir. It's only 5 minutes. I'm Gayatri Gorti. I'm a rehab psychologist. I'm working as researcher at Total Solution. So I'm here only to emphasize on 2 important points: that adaptive behavior of young children with autism in India. When I researched, it's only one study that was done in 2014 by Pratibha Singhi. Only that study was there, and adaptive behavior was found to be the main predictor for future adjustment of autism children with autism. So we have to do more research studies on ASD as well as adaptive behavior. I will share more information on this. Anyway, ASD you know all. I don't need to explain on this, but I want to say that the worldwide prevalence is 1 in 44 children, and now in 2022, April research study says that it's 1 in 100, and India also it was found that it's 1 in 100 children. When it's in 2012, it was 66 for 10,000. So now it has come to 1 in 100 children. So we should do more research studies on ASD, basic as well as applied research, because we are getting more and more cases. So what we have done really is we have planned for a couple of research studies. One, this is a preliminary study where we wanted to find out the adaptive behavior profiles of young children in comparison to children with non-ASD, that is having developmental delays. So we have taken 63 cases. Out of this, 23 children were non-autistic, and this 37 children diagnosed with mild to moderate autism and CARS. So we have analyzed and we have compared using CARS as well as VSMS and DST. And what we have found out is that both of their profiles are mostly matching. There is no difference between non-autistic having developmental delay as well as ASD with mild to moderate autism. Mainly because the sample is matching, one thing, and what we have found out is this is the profile which we have observed. It's mainly motor activity. They are very good at motor activities, activities of daily living, communication and socialization. So both of them are low at socialization as well as they are good at motor activities. But when compared to this, when we see the profile, these children with developmental delay, they are very good at occupying themselves, that is engaging in leisure activities more. That is the only difference. And when we correlated with the autism severity with this adaptive behavior, what we found out is it's negatively correlated. That is, when the autism severity is more, the adaptive functioning is less. And mainly when we see the individual areas, it's dressing and eating. What we felt is mainly having sensory issues also affected the severity of autism with respect to adaptive functioning. So major findings are these, and what I want to communicate here is the research says that please do more on adaptive behavior because this is the main predictor for future outcomes. It is not the IQ, it is not the what you call language, it is mainly the adaptive behavior. So please, future researchers, students, professionals, whoever is working with ASD children, please do some research on adaptive behavior, mainly the assessment, detail as well as intervention, because outcome studies, these efficacy studies are also very important. So that is what I want to communicate. Thank you.
So now I request you to felicitate Dr. Pooja. Now I request Dr. Manjula, clinical psychologist from Apollo Hospital, Jubilee Hills, to take over the stage. Her clinical interest is in licensed psychology, but has also worked extensively in child and adolescent mental health. The present topic is about a childhood behavioral problems, specifically bullying in the classroom context. Madam, and please do maintain the pace and try to finish in 20-25 minutes.
Sure, I'll do that, and thank you for the nice words. Now, this topic involves we create quickly a strong sense of community. Okay, so there will be a little activity, and the conference is all about child and adolescent. Would you like to become children once again? Please, it's a request. Okay, so quickly we'll take numbers. We'll count in threes. 1, so 2, yes, 3. Again, 1, 2, 3, quickly go on. 1,
Jaldi,
2, 3.
jaldi.
1, 3. 1, 2, 3. The light man and cameraman, we leave them. 1, 2, 3. Please take the numbers quickly. And remember your numbers. Quickly. 1, 2, 3. 1, sir. 2. Take up the responsibility, somebody. Quickly. Little faster.
2, 3.
Behind. Sir, blue shirt. Yes.
3.
Quickly. Yes, faster. Yes. Quickly. I think people here missed out. Yes, finish up here.
1, 2, 3. 1, 2.
Come on, 3.
Done? Yes. Now the second last row. Yes, continue. Please, quickly. Remember your numbers. Yes. Now all the ones, please come here. All the ones to come here. Sorry for the discomfort. Please forgive me. Please come here. Please. You promised you'll be like children, facing any discomfort. Please. Don't be angry with me. All the twos come here. You need to get up with your bag because the rest of the presentation you'll be here. And all the threes there. All the threes there. I can see the arrangements being made.
No classroom noise, please.
I think this is a classroom and we are talking about bullying. There should be noise, there should be bullying, okay? Alright, shall we start the game?
You can fight for the seats also then. Me first.
So we'll start the game now, okay? Tell me what is your favorite fruit? The number threes. Number threes here. Mango. Number 3's favorite fruit is mango. Number 1's apple. Number 2's banana. Okay. Repeat. Apple, banana, mango. Now I'll tell you a story. In that story, whenever the word fruit comes, all of you have to stand. Whenever the word mango comes, who will stand? The mangoes.
Three is mangoes.
The mangoes. And whenever the word apple comes, who will stand? The number ones. And the word banana, number twos will stand. Okay, if you're standing, you will sit. If you're sitting, you will stand. Are we ready?
Yes.
Let us check your attention. Once upon a time, there were two friends, Raju and Ravi. I hope nobody's name is Raju and Ravi. Okay. One day they went to a fruit market.
Come on,
Hey,
everybody
fruit
stand. Sir, you too. No principal in the class. Please stand up. You too.
Man, you're number 2. Yes, but whatever your number is, you have to stand for the word fruit. And in the fruit market,
Sit. Come on. We need
in
all
the
to
fruit
see.
market,
Be
they
attentive.
saw many fruits.
Yay!
They saw some mangoes.
Where are the mangoes? 3.
Mangoes.
Only 3. 3 has to sit.
Mangoes, not others. I said only mangoes.
Only mangoes has to
Mangoes
take the
will
position.
sit. Why are you sitting? I didn't say banana. They saw mango.
We need to alternate our
They
positions.
saw pomegranates.
No pomegranates. No one
I
sitting down.
know. They saw many bananas.
Yay! Bananas can sit now.
And they saw some apples too.
Finally.
And finally they decided to buy 24 bananas.
Wow.
And a few apples.
Come on.
And oranges.
So you don't change your position.
With these fruits, they went back home happily.
Fruits.
They were supposed to stand. See, now you saw the attention, how low it is. And they are saying the attention has become much lower post-COVID, post-pandemic. Okay? Yeah.
Before lunch, ma'am.
Now,
Post-lunch we don't stand only.
yeah. If this happened after lunch, he would blame me saying, see, we have full stomach, so. All right, thank you. So my presentation is going to be very small. It is a very simple one, not elaborate, just one-line slides. And most of it is very practical.
Nice exercise, right? I hope all of you will be attentive right now.
I know. So, the topic that you see in the souvenir is about the classroom behavioral problems. If you talk about classroom behavioral problems, there are a spectrum of it. So, we are not going to go into everything. We are going to take something simple as bullying, though it's not simple, but something which can be observable. And we'll stick to bullying today, okay? And some background about bullying is that it is a social phenomena more than an individual phenomena. So when something occurs in a social setting or a classroom like setting or a school setting, okay, or a workplace setting, then the preventive intervention, the preventive measures also are focused on that social setting. It's not about individual therapy or individual intervention. Later, this intervention part, the therapy comes into play. But whatever preventive measures we have for bullying today are all focused on the social setting, the classroom setting. So this is according to the 2021 November UNICEF Bulletin. It is estimated that nearly 1 in 5 students is bullied. It's a very sad picture because in the past few years in my practice, I have seen patients whenever they are in transition into a new job or from college to workplace, this one phenomena affects them very badly. They come back to the psychologist saying, look, I'm rejected here, I'm discriminated, I'm treated in another way. And the impact of all that they have faced from childhood, it has a huge impact in the present day. Okay. And this bullying has these three factors, it is a purposeless behavior. We can't say completely purposeless. The person who is doing it has some kind of, happy pleasure, not happiness, pleasure in doing it. Other than that, it doesn't really serve a larger purpose. And it's an aggressive behavior. It's a real power imbalance, or it can be perceived. Okay. And it is repetitive, and it has the potential to be repeated over time. So the combination of these three factors creates a situation that moves beyond conflict. It's not just an ordinary fight or anything, but it becomes a persistent persecution. Remember this, it becomes a persecution. That is where the person suffers. Okay. And it is actually the strong preying upon the weak, what we find in the animal kingdom. It can be a physical advantage or a social advantage. Like some children grow taller, heftier, change their voice more quickly. I mean, they develop secondary sexual characteristics more fast than the other children. In that case, they believe that they are stronger than the others. Or it can be a social advantage. I'm a politician's son, I'm a rich man's son, or whatever, or a daughter. So it can be one student bullying many, or the opposite. One student being bullied by many other students. And it can be, it often takes the form of threats, intimidation, repeated cruelty, and or forcing someone against his or her will to do what the bully wants him to do or wants her to do. So what we take away from here is the phenomena of bullying. The fourth point is the phenomena. What really happens there? These are the things. So I was told there are many teachers who are attending this conference, so I've kept it in the focus of teachers and the school personnel. And also some parents are attending, so I've put it very simple. So all these are preventive measures. As I told you, these are something very simple and you can take it with you. The first step to prevent bullying is talk about bullying. Make it a point every week at least the teacher talks about bullying. What bullying is, what happens in bullying. And let me know if any of you are going through this. This is what the teacher is supposed to say. And let the class know that the teacher is an advocate for anti-bullying. Every child should know that my teacher is not going to tolerate bullying. She's not going to beat me up or anything, but she's going to be unhappy. And the consequences are going to be really, really bad. So, this has to be made known. Placards can be put out, or some small posters can be made in the bulletin board in the classroom to send this message. And there are some places where bullying is done, especially near the washrooms, when the teacher is not in the class, okay, the corridors. So this is what you have to keep in mind. The teachers have to be visible. Give a sudden appearance. It's all right for a teacher to go near the washroom now and then. It's okay. And keep yourself informed and alert. Read up the recent evidence about bullying. What forms bullying can take. I'm not talking about cyberbullying. We'll keep that away. This is not a part of this topic. And whatever other information and updates you have about this, the teacher has to read up. Okay? And become familiar with the bullying indicators. Do you know what are bullying indicators? Physical indicators. There will be cuts and bruises and scratches if they are bullied physically. There will be mental, emotional indicators, psychological indicators like, your sleep is disturbed, eating is disturbed, speech is disturbed, you mute yourself, you don't talk much, and also you see your younger sibling beating or treating in the same way the bully is treating you. Okay, these are some indicators, and there are many, many more. Please read up. And as well as there are cognitive indicators where the child loses interest in academics. The child is not willing to go to school or participate, or homework is not done with great interest. Okay, so these are some indicators. And in the parent-teacher meeting, teacher can ask the parents, or now and then when they have this sessions a talk session in the class, they can find out if anybody has any of these indicators. Increase bullying awareness among parents. Have a session with parents, or whenever there's a meeting, please do talk to them about bullying, that all our children can be bullied and all our children can bully others. Okay, nothing to take offense. Let us just have a look at them. And teaching students to be effective bystanders. This is very important. Teacher can't be everywhere, but telling students stand up for the one who is being bullied or stand up against the bully. We can teach this to children and they very well follow it. And groupisms have to be stopped in the classroom. There's a beautiful quotation by Jawaharlal Nehru. I'm not his fan, but I'm just telling you his quotation. He said, "Fortunately, children have no barriers and we have to make use of it." Okay, so let us make use of this mind of theirs without any barriers, saying that we are all equal. There's no black or white. I'm talking about the West. In our culture, it's more of community, the social, status. We can talk about this. And keep a close eye on the situation. So once you do these sessions, you're creating bully awareness, then have a close, watch over the situation and respond quickly to every bullying incident. The moment you hear there's a bullying going on, you have to respond immediately. That is, check in with both. You have to speak to the victim privately, separately, and the bully also separately. Okay? Don't talk to them together. Because if you talk to them together, there won't be any resentment in the bully. He'll find it, he's getting the attention. That's what I wanted. But when you talk to them separately, there is a kind of resentment and a bit of, fear for doing a wrong thing. That's what I mean, not to scare the child. Creating a sense of community. The game, which was so stupid now we played, was a silly game, but then it created a sense of community. This kind of shared activities have to be there at least twice a week. If not every teacher, at least one teacher can have some activity where every child has that opportunity to show that burst of energy. Okay, so a sense of community can be created. It can be done through storytelling. It can be done through such shared activities, okay, or discussions, but please do it. Establish your classroom as a safe place. Tell them this is a place where you can talk about anything. It is a non-judgmental place, and we will tell you how to communicate better and what to talk and what not to talk, which can be socially, disinhibiting. All that can be taught in the classroom so that every child has an opportunity to talk about what is happening in his life. But when he sees we are judging him or we are not validating his point, he just keeps quiet. Okay? This is one small pledge I found on the internet. I copied it. You can use it in the classroom. And here is the last slide, but it is not the least one. Teachers, if you find it is difficult to handle, remember there are psychologists. Please remember us. Parents, do remember us. We also do great work, and we do a great work in this field of, intervention, providing for the victimized child as well as for the aggressive child. This is where psychologically the clinical history is taken, noted down, and then assessment is done. So far we didn't talk about assessment because it is only with the symptom that the victim child comes and tells you, you take action. And assessment there's one standard assessment which you have to buy. This is called Bullying Participant Behavior Questionnaire, which is a 4 questionnaire. 4 questionnaire subscales are there, in which the bully's questionnaire is there. The bully's assistant also has, bully is not alone. He has a big gang. He goes around in gangs. And the victim and the child who has witnessed the victim, that questionnaire is also there. Okay, so that gives a complete picture. The last reference, person group dissimilarity in involvement in bullying and its relation with social status, which is from the Journal of Abnormal Child Psychology by Wright and his colleagues. I want you to read this. A beautiful 12-page research article, okay, which talks about bullying and why it happens and all that. And the other one, Elderman, is an old study, but which has been updated. That's a beautiful book, Social Powers and Effective Classroom Management. And this is a section from Enhancing Teacher-Student Relationships. And the chapter is Intervention in School and Clinic. And then the UNICEF Bulletin, of course, there are no researches post-pandemic bullying increase or decrease. Okay, this was a general topic which I have selected. Thank you.
Well, first of all, thank you for finishing in time, ma'am.
I thought so.
That's perfect. I appreciate that. And outline of the bullying is pretty important. You cannot cover the deepest part because it usually depends upon why the the child is doing bullying and how the other victim is suffering from that. The only part the evaluation comes. Most of what I'm seeing at the case of Nilofara, most of them are school refusals. They present with school refusals than most of them, or pseudopain abdomens, or multiple somatic complaints like headache. They don't want to go to school. They refuse to go to school. Because of this, the most common thing which we see is bullying, where the school refusal is the most predominant complaint. This point I want to add. Any questions? Any doubts?
There is a disease which is not mentioned in ICD-10 or DSM-5, which is called hikikomori syndrome. Okay, if you've heard of it. School refusal is a prominent thing, and there is evidence of hikikomori increasing post-pandemic. Japanese. Yes.
I would like to know, like I've been decades in the school area, like a child who's being bullied, generally whom does he has to approach in the school? Do we have any such arrangements?
Okay, you're talking about the victim.
The victim.
Who has to...
Yes,
yeah,
within the school.
Yes, the immediate person he can approach is his class representative. If the leadership training is important in the school, then class leader can do a great thing for the child. And then his class teacher. So every, I don't know, most schools nowadays have someone called a mentor or, a mother teacher or something. They can approach them.
And another thing I have observed, this is my observation, and they just put up no bullying and all that, and we see bullying happening right after that side.
Yes, ma'am. It's like no urinating and urination happening right there. So why do we do that? It's like a small game I'll play with you now. I'll give you a command and you have to follow that. Everybody touch your cheek. Okay. All right. So some of you have lifted your hands. Why did you do that? Okay. So we have this bit of, oppositional defiant disorder, just modeling as let's visit, sorry, taking just 10 seconds more, Albert Bandura's, learning theory. We just model or learn from experience. That experience gave me pleasure, so I'm going to repeat it. The consequence is what maintained it.
Thank you so much, ma'am.
Now, I request Dr. Rishgaru to felicitate you. Please come over here. Just 2 minutes. Photo time. Okay. Now we have one more session before lunch. After that, we'll take a small break for lunch. we'll come back for the certificate distribution, and we have 2 more talks. That's today's schedule for it. Okay. Now I request Ms. Wahini. She's a senior research fellow from National Institute of Nutrition, Hyderabad. She has over 11 years of experience in nutrition counseling. And can we restrict the movement, please? That's okay. We can go back after the lunch. Okay, let me continue. See, I'm getting distracted like in the classroom. So Miss Wahini has 11 years experience in nutrition counseling. She's currently working as a consultant nutritionist for Nirvana Nutrition and in NIN. She did her doctorate in nutrition from Osmania University. She has done her doctoral study at ICMR, National Institute of Nutrition, during which one of her papers has been awarded Young Scientist Award from UGC. She has, for her research on the diabetic meals, she has given many nutrition talks in media, and now she's here and the stage is open for her. Madam, please try to maintain your time pace to 20 minutes.
Good afternoon, everyone. I apologize that I might have stopped you people from going for lunch, but I think very little time. Thank you so much. And thank you, ma'am, for my introduction. Thank you, sir, for calling me over. So I'm going to talk about, that's not so clear, but the topic is food and mood in adolescence and the real deal about mindful eating. So mindful eating is something which we all should know. That's where I put more my focus in my presentation right now today. And as we see, adolescent nutrition, the age 10 to 19 years is considered as adolescent, but above 18, everybody considers them as young adults. So they skip this group. So they are free from all kinds of eating, or they can go for fat diets. And when we go and ask, when the parents go and ask the children, like, why are you doing diet? I'm an adult, I crossed 18, I don't have to eat what you're making at home. Children might answer like that. We can hear children answering like that. But they are still under adolescent age and they still follow the same norms. So adolescent age is a very crucial age because they gain the 20% of their adult height, achieve 50% of their adult body weight, and accumulate 40% of their skeletal mass. So now there's so much of growth happening in their body. So what should we do like? What should be happening like? There should be a lot amount of food to be consumed by them, right? Because the bone, the skeletal mass is increasing, the body weight is increasing. So there's a lot of blood volume which is required. So any deficiency of any nutrients at this particular group can cause a lot of cognitive disabilities. So in a recent Pan-Indian survey, they have documented that greater than 50% adolescents are either wasted. Do you understand by the term wasted? Not like they're getting wasted. Wasted here, it means like they are more for their weight for their age. Like for example, if they have to be like 40 kilos, they are like 65 kilos. And the reason could be lot of junk, lot of TV watching and eating. So these are the other reasons. I'll come in my subsequent slides about it. So stunted, overweight or obese, and over 80% are suffering from deficiency of one or more micronutrients, majorly iron, vitamin B12 and vitamin D. You know why iron, B12 and D specifically? Because iron and B12 are mostly present in non-vegetarian foods. Many children who are vegetarian do not get them from their food sources. And mushroom eaters, maybe they get little bit of them. And vitamin D. If you see, previously, children used to pay a lot in this playground, right? And now it's more about exams, academics, tests, or online teaching. And past 2 years, nobody has seen sunlight. Isn't it? We all also might have vitamin D deficiency, subclinically somewhere, but we will not come out of it. But children are more affected about it. So I'll show you something. This is called food pyramid. On the left side, you see that it's very well placed. I'll explain a little later about what NIN has done with food pyramid. If you see a lot of vegetables on the ground with a larger scale, and as you go up, you see the junk in the lowest category, right? Like the cheese or the red meat. I don't call them junk. They are also good foods actually. So now you see the environmental pyramid. How is it? It's much practical, right? Which according to you is more practical, the food pyramid or the environmental pyramid? That has to be followed, but I believe we follow environmental pyramid more, isn't it? Yeah, because we eat more of non-vegetarian in the form of KFC, McDonald's or something like that. And lot of biryani because we are from city of Hyderabad. Then milk, lot of milk we consume because we can't live without tea at least 2 to 3 times a day. And tomatoes are the ones which we at least consume in a day, if not any other vegetable. Because we have to at least put that at least in the dal, right? Or in the salad. So what I'm trying to tell is environmentally we have changed our eating practice and more so our children and so the adolescents. Even the box which you're packing or whatever they are ordering, everything goes mainly for the first 3 lines. They're not following what they have to use, like no green leafy vegetables, no fresh vegetables. All these things are not consumed much. So there are many mental disorders and some known ones are anxiety, depression and others. I will be concentrating only on eating disorders, but my more focus will be about mood enhancing and mood depriving foods. Because I'm a nutritionist, I'll be talking more about food rather than psychology. Okay, so what are eating disorders? Eating disorders can be an over intake or a lesser intake of the food because of various psychological changes which they go through. And what are the common types which we see? And you must have been listening since yesterday. Binge eating, bulimia nervosa, and anorexia nervosa, right? Okay, so what are the symptoms of these eating disorders? Let's see a little bit. Suppose it's binge eating disorder. One person will eat until they are uncomfortably full, right? Suppose I give you one big bucket of popcorn, watching a movie. Will you complete it or will you share with someone? You'll share with someone. But suppose if you have come alone to watch a movie, you have no choice. You will complete it all by yourself, uncomfortably even if you're full. And eating to ease stress and anxiety. We are extremely happy. You won gold medal from your university. Undoubtedly, you'll go eat whatever you get in the market. Then recording weight fluctuation. You must have seen that joke. I don't know why my mother, whenever she sees on this weighing machine, she'll cry. But technically she's seeing the weight and crying. She's not crying because that is hurting or something. But weight fluctuation. So whenever you see that there's a lower weight, you'll feel like, oh, I can eat. I'm free to eat now, right? You can eat whatever you want. Whenever you see that the weight is going a little high, you're like, oh no, I should starve. I shouldn't be eating now. So this is what you come to random conclusions for no reason. And more so in adolescents, it will be more frequent. Then consuming excessive amount of food for no reason at all. Then feeling desperate to control eating and controlling yourself. I've seen one of my patients, she wants to lose weight. She is perfectly alright. But she just wants to maintain that forever. So she eats only 1 apple in the breakfast and survives with that till 3 p.m. Because she wants to maintain that forever. And at 3 p.m. she'll eat 2 guavas because I told eat more of fruits and vegetables. So she forgot cereals along with TV serials. So after going home, she has to eat dinner at least, no? Now she stopped eating. The body has adapted to small eating. The stomach also is not taking much food. So suddenly, randomly, 1 week she had to eat rice because she went on some vacation with someone. After she came back, she says, I have lot of knee pains. It should technically not happen, but why did it happen? Because the body got used only to vitamins and minerals. The protein was getting excreted. So excessive protein which she consumed from the rice got accumulated in the bones and created gout or uric acid, excess uric acid in the body. So this is what happens if children over a period of time randomly stop eating rice, wheat for no reason at all. Then what are the symptoms of bulimia nervosa? It's like again same binge eating, then again self-induced vomiting. First you'll eat for no reason, then go to the bathroom and vomit feeling that you have eaten more, and then again binge eat because you feel you have lost a lot of electrolytes. Then you have anorexia nervosa. You must have heard a lot since last one day, so I won't talk much about it. So mindful eating versus mindless eating. That's what I'm going to tell about now. So if you see this picture, you think both are same?
Yes.
The serving size? Yes. Exactly. But if I serve this to some person who's extremely hungry and to some person who's not hungry, 2 people are sitting here and I give them these 2 plates. The person who is extremely hungry will say, give me a big plate but little quantity. You give the other person small plate but bigger quantity. It's just a pictorial illusion. But this is called mindful eating. So whenever you tend to have a bigger plate, if you want to eat less, that doesn't mean take more food, take a bigger plate and you feel like you're eating less. Or you take a small plate and put more of food. What we're trying to tell is, the smaller the plate you keep, the better you eat. But here, if you see the picture, the ma'am said she asked us to eat in smaller plates. So we'll eat one roti, other curry and half keera or 1 or 2 onions. So again, you're cutting down on your vegetables. You're increasing more on the cereals. So you should know what combinations have to be increased and what have to be decreased. So we eat for many reasons. Parties, rituals, social, farewell party, marriages, occasions. It could be any reason. But what is the one reason we should eat? Only when we are hungry, right? So what is mindless eating? Eating because it's noon, right? Suppose if the lunch was not served now and it is served at 3 o'clock. Imagine you were served very good lunch at 12:30 and again you were given very beautiful snacks at 3 o'clock. Will you consume? You will definitely consume because they are given, right? That will indefinitely happen. I see it, it looks good. Okay, how many of you have felt this? As soon as the Sitafal season came, wow, Sitafals, I have to have my session this time. And you don't stop with one. Same goes with mangoes. No one can eat just one. It should go for mango, not for lace. Then it smells good. Okay, how many of you get this thing? Somebody else is making chicken biryani in my neighborhood and we made dal roti today. That smell is nice. I'll chuck this, I'll order in Swiggy. That will happen. So I haven't finished what I served. This is very common. Some people feel like I didn't finish the food. I have to respect, I have to do puja to my food. They are served so much, so I should finish whatever is there. And then overeat. Then it's free. Whenever we're getting free goodies, imagine you're watching Bahubali in theaters. Bahubali is out now, but I'm giving an example. But the tickets were expensive. But they gave you 2 tubs of popcorn free for 1 person each. You will definitely finish it because it's free. It is what I always do, okay? And you justify yourself. I always have popcorn when I go to movies. It is not like they're giving for free. It's just that it came free, so I have to eat it. So these kind of justifications you give. All this is called mindless eating. So what's the difference between mindful and mindless eating? Focus on the next bite and the environment. I guess the titles have been switched. I'm sorry about that. Because while the formatting has happened. Maybe I was not mindful while changing the format. So it became a little mindless here. Or am I joking? Is it same? Can you please tell after reading this? I was joking, it's actually the same. Mindless is mindless, mindful is mindful. Oh, I'm glad everybody is concentrating. So what does mindless eating means? That you don't focus on the next bite and environment, right? Suppose we are eating a good KFC chicken bucket. How many of you are non-vegetarians? I'm giving a lot of non-veg examples. Oh, they are. Oh, okay, that's a good number. Suppose we are eating mangoes. I'll go back to vegetarians. So it's mango season. We have 1 kg of mangoes which have been delivered to us for free from some organic company. So you'll not stop with one. The moment it starts, like my craving doesn't end. I cannot live without eating 2 or 3 mangoes at least. And end up having other disorders like pimples and acne and blame the mango for that. Then eating with intention while paying attention. So always we should concentrate on what we are eating. Finishing what is there in the plate is not doing puja. Understanding what you are eating, relishing what you are eating is what is called respecting the food. Then it lowers the awareness of amount of food and consume, right? Suppose I'm going for the mindless eating. Like you won't be aware of what you're eating, right? It lowers the awareness of amount of food you consume. 1 bucket of popcorn khatam ho gaya, ek aur free hai, usko bhi khatam karna hai. So you'll keep on eating. You're not aware of what you're doing. Then choosing foods you enjoy and that nourish your body. So this doesn't mean I like pani puri, so that will nourish my body, so I'll add that. Because I said choose the foods which you enjoy, right? It again comes a little bit with nutritional counseling here. Then awareness of why I'm eating is very important in mindful eating. Whether you are comfortable to eat it, whether you are emotionally happy to eat it, sad, glad, mad to eat it, all these include emotional eating. I'll give you a classic example. Some nutritionists tell, I don't want to tell all nutritionists, whenever they say you're dieting and they want to go for some fad diet like intermittent fasting, so 8 hours of fasting and 8 hours of eating, anything is allowed. That's what they say in intermittent fasting. Do you all know intermittent fasting? So 8 hours I can eat anything. It includes anything, right? What does that anything include? It could be chicken, it could be a lot of fruits, it could be a lot of vegetables, it could be biryani, it could be dessert, it could be Maggi. Everybody's favorite. What does that justify your fasting? No. What does intermittent fasting also say is that 8 hours also you should consume very nutritious food, because you're depleting all your nutrients in the last 8 hours. You should come back to having a lot of cereals, lot of fruits and vegetables, lot of nuts and oil seeds, little bit of milk and little bit of ghee. That's what they mean that. So eating mindfully, you can use the scale, then slow down every time you eat. Understand what you're eating, chew completely, then go for the next bite. Don't eat in a hurry. Take small bites, then practice mindful bites. What are mindful bites? Same like notes which you prepare for exams, small tiny notes. Similarly, small tiny notes for food. Breakfast, I should eat idli and chutney. Prepare yourself. Eat 2 idlis and chutney. That's enough. Don't go for 3 chapatis and aloo ka paratha. Or don't. I'm not telling they're bad, but the quantity. Lessen your quantity. That's the only thing. Then environmental cues. Right? Chips are there in the cupboard. They are calling me. I can't do anything. That's one option which you always find. Goodies are at the movies, so I have to go to the movies. Drinks at social events. They are free. You can't avoid them. Then snacking after dinner. How many of you do this? Oh, nobody does. I do. I can't live without a dessert after dinner. Game night, whenever it's game night, nobody controls, have a control. And all these are very common in adolescence. Yes or no? Then finger foods, French fries, the highest sold product in Hyderabad right now. Then dessert after dinner, boredom, we are bored. So what do? Let's go hang out for some coffee. We don't stop at coffee. We don't start at coffee. We start with something else and end with something else. Then TV watching and eating, everybody does. And buffets. You know, buffets are the biggest scam. There's a lot of food. You're paying a lot of money. Your inner feeling will like, I can't just eat 2 or 3 sips like this. I'm paying 700 rupees. I literally have to eat every bite of it. Isn't it? All these are called mindless eating. So there are many strategies to avoid mindless eating. First, know what are high-fat foods. Right? How many of you think that biryani is a high-fat food? Yes. High-fat. High-fat. Anybody, please justify. Yes or no? There's only one person who feels it's high-fat, nobody else. Okay, 2, 3, 4, 5. It's actually high-fat but a low glycemic index food. You know what is low glycemic? That which releases the sugar slowly. How? It's rice, it should be high glycemic index. It has lot of ghee, it should be high glycemic index. Yeah. Exactly, and also because of the oil which you are adding in it. And more importantly, the spices. We always forget our spices. Spices are rich in antioxidants. Whenever there's antioxidants, the glycemic index is low. So you add any spice. What are the common spices we eat? Jeera, mustard, every day it goes, right? Other than these, those are condiments, but they come in the same category. Other than these, when it comes to biryani, we go a little ahead with dalchini, cloves. Yeah, so all these help in reducing the glycemic index. So that doesn't mean ma'am told we can eat biryani, so we'll have it in lunch and dinner every day. Your glycemic index will be low, but your fat cholesterol level will go like this. So then limit your eating to just one place. Always remember, if you're having a habit of eating at the dining table, if the child is having the habit of eating at the dining table, make sure he eats only at the dining table. Guests have come, we'll shift to the hall, we'll watch TV, we'll do the gaming. Don't do this. Don't allow this neither to yourself. First we have to follow. We shouldn't do this, and then the adolescents don't follow that. Limit other activities when you eat. How many of you do this Instagram scrolling while having lunch? This is a nice post. This is a nice video. How many of you do this? I do this because I eat alone in the office. I have no other option, no friends. The mobile is my only friend. I put my mini TV and I eat. And I don't know how much I'm eating. So all this thing are distractions to control your eating. So hungry, angry, lonely, tired. Always diagnose these 4 things in the children and see and explain to them that only if they are hungry they have to eat, not when they are angry, not when they are alone, not when they are tired. Then, so okay, so what are the mood enhancing foods and the negative effect on food? Okay, let us look at the mood enhancing foods. Fatty fish, they have high DHA, docosahexaenoic acid, which is very good for children. Most of the products, Cerelac, Nestum, everything, they put artificial DHA for the development of brain in the children. So why are we putting a supplement to a child? Just get fish. Then chocolate, okay, it has N-acetylethylamine, which helps in production of dopamine. Then you have fermented foods. It increases the serotonin 95% from the gut. Okay. Do you know this gut-brain axis theory? The fermented foods of the gut release the hormones or increase the hormones. Am I correct? Release the hormones or increase the hormones? They increase the hormone content. Yeah. So similarly, all the fermented foods, they increase the serotonin. Then banana is very rich in vitamin B6 and dopamine. What does vitamin B6 do? It's also called pyridoxine, which is very commonly given when you have neurological disorders. Then oats have a lot of fiber and iron. All the fatty fish which you are eaten, it has to be eliminated from the body. So oats is our vacuum cleaner because it has a lot of fiber. It will clean the excessive fat. Then you have nuts and seeds. Nuts and seeds have tryptophan. Tryptophan is precursor for very neurotransmitters, so hence it is very important. Then coffee. This is a contradictory food. It is there in both the categories of causing positive effect and negative effect. Then beans and lentils, it has serotonin and dopamine. And GABA. What do they do? What do serotonin, dopamine and GABA do? Happy hormones, exactly. So if you want to feel happy, just go have some khichdi. Okay? So foods causing negative effect of mood. अच्छा बोलते भी हंसी खा गया. Very good. So food causing negative effect on mood. Soda. Simple sugars contain soda. It creates a similar belly like alcoholic belly. So don't have cool drink with every biryani you eat. Very common in South India though. Cocktails and high sugar mixes, they contain, these, you can again say they are not aerated drinks, they are not sodas, they're just high sugar and we are having not oftenly, occasionally, so they should be good for us or something like that. No, it is not like that. You will get used to. That is the first thing. Then you will get irritated and depressed as soon as you eat them. Then vegetable shortening. Example is mayonnaise. Okay, what do mayonnaise do? Mayonnaise is just vegetable shortening. Like basically eggless mayonnaise. With egg mayonnaise is a different story. How are they blocking the omega-2, omega-3 fatty acid? Omega-3 fatty acids are present in the brain. And these vegetable shortening increases the cholesterol and does not allow the omega-3 to work. Then cold cuts, the preserved non-vegetarian food. They contain high nitrates. What happens when high nitrates or sodium is present? Exactly. Water retention and then bloating of the stomach. When there is excessive water, you feel like eating more sugars. Then salted peanuts, again sodium, causes water retention. Baked foods, high sugar and trans fats. All processed foods also come into the same category. Now look at coffee. It was positive. Now how is it becoming negative? So our body produces cortisol whenever we are drinking coffee. What happens? It goes. It's just like glycemic index, resulting in physical and mental functioning better after you drink coffee. Then what happens? It will not be here. It will come down. And this crashes. It doesn't come down slowly like this. And when it comes down, you're back to much worse phase than what you were before drinking coffee. So that's the negative effect you have with coffee. So there are some few frequently asked questions which are given by Indian Academy of Pediatrics. So what are these questions? My son is growing older. He has become picky eater. How to change his eating behavior? Right? Until he was 7 or 8, whatever mother used to give, that son needs to eat. Now he's teenager, he won't eat. What you'll do? They'll have problem, like we can't do whatever. The solution is involve them in buying, planning, menu and in cooking. You can take them to supermarket and ask them to buy. Ask them to buy for the whole family. You pay the bill, but you just tell them to plan what has to be bought. Then try to lessen the stresses, involve them in physical activities because most of the adolescents are busy studying. That's the most important thing. Again, ma'am discussed that even bullying is one more very important factor where whenever they are bullied, they are very mentally challenged and they don't tend to eat food easily also. At that time also you need to understand the cue, talk to them and then get them involved in this activity which might deviate them from their depression. Then second question, my daughter takes the meal we provide at home and looks healthy too. How will I know whether she is getting adequate nutrition? This is called over concern. Or not? Should I monitor her calorie intake? So how do you do this? Check if they are looking pale. If they are not looking pale, it is like they are having a healthy weight or a healthy eating pattern. Check them if they are eating similar to their mother or little more than that. It is absolutely fine because that's a growing age. Then check their weight and height every 6 monthly and check their hemoglobin levels. That will affect the cognition a lot. Then there are many questions. Of all that, I would just like to explain this food pyramid a bit because this is very important when you try to counsel your children or your adolescents that majority of the food should be from cereals, little better from the vitamins and minerals from the vegetables. Meat and oil should be consumed little less, and junk food can be taken but sparingly. Now you should be telling, madam, from that time you're telling they are mood depriving. Why are you telling them to eat sparingly? The reason is we can't avoid junk food. There's a farewell party in the college and no junk food allowed. So what will be the cuisine? Ragi laddu? Khichdi? Nobody will come. Similarly, even imagine a wedding or a birthday party without any good food. So these are something which are very inevitable. We can't avoid, hence they are put in each sparingly group. And this is my plate for the day, developed by NIL. How do you think? Do you think this looks practical? Not so? But I'm telling you, all of us are following this except for one effort which we need to put from our side. That's for about consuming that fruits which are of 150 grams. Rest everything we do it. But the only thing is we do it in monotony. But here we are trying to do it in different using different foods. Briefly, I'll tell you. Suppose cereals and nutri-cereals, it's written you should eat 240 grams, right? So 240 grams in 3 meals is how much? 80 grams per meal. Are we not having 80 grams per meal? 2 rotis is 80 grams. It's quite possible. In fact, we are eating more than that if I'm not wrong. Then vegetables, it says 340 grams. Nobody makes 100 grams of curry for oneself, right? They'll at least make 1 kg of curry for their entire family. So that's also possible. Similarly, eggs, pulses also have the same theory. Nuts and seeds, everybody says, whenever I say nuts and seeds, what are the examples of nuts and seeds? Dry fruits. Flax seeds, everybody is very rich, sir.
Peanuts.
Peanuts. Because I said rich, everybody started thinking what we get cheaply. Okay, so peanuts, coconuts and sesame seeds are the cheaper sources of nuts and oil seeds which you can get very easily available. Sesame seeds are also expensive, but the quantity is more for the amount you buy it. So these should be taken at least 20 grams. 20 grams is not even handful. Is it impossible? It's not impossible. Then the last thing which is happening here is fats and oils. I say 27 grams of fats and oils. Now we all say this is joke. It is impossible. Nobody can have 27 grams of oil in a day. Yes or no? Is it possible? You'll say, no, my mother, or when I cook, I will take the whole wok like this and I put oil like this and I make. I can't have 27 ml of oil in a day. It's not practical. So I say it is practical. You're not making for yourself. You're making for the whole family, which is around 100 ml for the whole family, which is quite practical. So that way, if you calculate, you are having more or less 30 ml only per day. So that's my plate which I wanted to tell more keenly. That's very important for adolescent children. Then apart from that, we have 10 dietary guidelines. You should aim for fitness. You should aim for healthy weight. Teach all the adolescent children what is a healthy weight, what is the height for age, weight for age. Then be physically active each day. Don't be like this couple. So don't do that, okay? So build a healthy base. Teach them food pyramid. You can make pamphlets in your clinics or in the schools, colleges, anywhere. Most of the government schools right now are implementing food pyramid in their schools. I've seen a couple of schools in Hyderabad. They have big poster. Then choose a variety of grains daily. And don't eat just wheat and rice. Go for oats. Little expensive. Okay, go for bajra, go for foxtail, go for ragi, jowar. All these you can buy. Almost the same price. Choose a variety of fruits and vegetables and keep food safe to eat. And then choose sensibly. Choose a diet that is low in fat. And lastly, I would like to say, if you drink alcoholic beverages, do so in moderation. So that's all from my side, and thank you.
Any questions?
One question, but
Many questions should be there. Mindful eating.
You were showing such beautiful plates of food, and then it's just before lunchtime. It was very hard to control.
Yes. You can start practicing mindful eating from right now itself.
I think we can take one question.
Yes.
have any suggestions for autistic children, because there's a quite good like keto diet and
So the first thing,
less enough carbs, no carbs at all, high protein, and they're very small. Doctors won't be able to prescribe them proper food. Fruit, banana is a big no. So I don't know, when parents come to us, it's like a big challenge for us to give them guidance.
See, what exactly happens in autistic thing is the doctors usually prescribe a gluten-free diet and a banana-free diet. The reason is the gut is not well developed, so they can't give them banana often. So you can put for alternative sources for banana. You can go for papaya, you can go for guava, you can go for oranges, you can go for many other fruits. Banana is not the only thing. Then gluten-free, you need to understand whether the autistic child is food intolerant or food allergic. Both are very different. If he's intolerant to wheat, don't give him. Most of the autistic children are intolerant to wheat. Many are not. So randomly don't remove wheat from their menu. If they are allergic to wheat, how do you know the difference between intolerance and allergy? Intolerance, you'll know it very immediately. Like the symptoms will be seen very
The rash.
and all that thing. Allergy, it will not be so common. It will be a little later. So if they have like wheat 4 or 5 times, like the entire week, maybe Saturday or Sunday, they might show some effect. So that time you can do an elimination diet, use wheat, then go to rice, then come back to wheat, then they'll get used to. That's the thing you can do. Rest all foods are allowed for them.
They're hyperactive because mostly the condition is ADHD and ASD. So they're not diagnosed with ADHD, but they are hyper. So they are being prescribed OT.
Okay.
Therapy.
Hmm.
So then this picture comes in. So is it true that carbs will increase hyperactivity in children?
The logic is simple carbs will increase the hyperactivity in children. All simple carbohydrates are sugars. When sugar is high, they are hyperactive. So look for complex carbohydrates. Go for oats. Go for ragi. All these are complex carbohydrates. You give them, they don't have that spike.
Thank you.
Thank you.
So thank you, ma'am. Thank you for the lovely presentation. So,
I request Dr. Manjula to felicitate ma'am. Over there on stage. Now I would like to announce the Best Paper Presentation Award. I request Dr. Hrishikesh Giri to be on the stage to felicitate the presenter. It goes to Ponadanti Vaishnavi Devi. She presented on stress in parents of children with autism spectrum disorder. Is Vaishnavi here? Vaishnavi. She's a psychologist from Let's Habilitate Clinic, Hyderabad. She did it individually. Vaishnavi, come on, run. All are waiting for lunch. A big applause to her. The way she presented really describes her profession. Good job. So please be on the dais for a minute. Yeah. I want Dr. Nitya ma'am to come onto the stage and felicitate Dr. Hrishikesh Giri Prasad Garla. He is the president of the organization committee for the studio workshop. we'll have a certificate distribution, and there are two more talks on for today's conference. We can all stand, go for lunch, enjoy the aroma, and practice mindful eating. See you all soon.
Thank you very much. You are at the right time. Thank you, sir, for scheduling before night.
Jyotsna, what is the lunch break time? Half an hour or 1 hour? Half an hour.
What is supposed to do with the chair? Just summarize.
ఇప్పట్లేదు